Keith Phelp, Ben Sharland, and David Freeman, although I believe he will be joining us later.
Yeah.
We are quorum. Are there any declarations of interest? Well, I have one, which is for myself on item 7, at which point I will be handing the chair over to Rob, who is online. And if he should disappear online for some reason or other, Lisa, would you chair at that point? Thank you very much. This is the last meeting today, in fact, for both Lisa Harwood and Keith Phelp. Keith, unfortunately, isn't with us. But just before we start, I'd like to say a few words about Lisa. She's been with the ICB board since it started, and therefore she is a big loss to us in terms of both her commitment and the amount of work she's always done over the time she's been with us. She's really given an awful lot to the committee, particularly to the People Committee and to the board. So we wish you all the very best for what you're going on to, Lisa, and thank you for everything you've done for us. Okay, so moving on then to the minutes of the Part 1 meeting. Are there any issues here that people would like to pick up in terms of either accuracy or areas that they wish to discuss something on? In that case, the minutes are approved. Looking at the action log then. Oh, apologies. I should have said that this is a meeting in public, not a public meeting. Normally, if we had anything from the public, it would be in the form of questions, and we have no questions from the public today. So looking at the action log, all of them have been completed. Everyone happy with that? Thank you. Moving on then to standing items, and we will be looking at a maternity board story, and we have Hannah Leonard and Rachel with us today to also have their input in it. So Jane, I think it's you setting that up, is it? No. Right, okay.
Thank you, everybody. So we welcome this opportunity today to talk about maternity services in Dorset. As you know, maternity has been a national focus for several years, particularly around concerns around safety and quality of care. And I think it's an area that continues to dominate in the headlines, particularly when we hear the very emotive and poor experiences of families who are using our maternity services across the country, which are obviously not consistently good. But I feel very privileged actually to be in the position I'm in today in Dorset in terms of how our maternity services operate for the women, their babies and their partners. And so I'm going to hand over to Harriet, Hannah and Rachel, just to give some insights into maternity services in Dorset. Thank you.
Good morning, everyone. Hannah Leonard, Deputy Director of Maternity and Perinatal Services in NHS Dorset. Just to give a brief overview for those of you that may not be as aware about our maternity services, we support about 5,500 births in Dorset across both 2 acute hospitals and a community setting. Like everywhere else nationally, our birth rate is falling, but our acuity is rising. The latest statistics show that about 1 in 4 women now are entering their pregnancy over the age of 35. Only a third of pregnancies start with a normal BMI. Diabetes in pregnancy, women are starting with about 12%. 12% of women are starting their pregnancy with diabetes, which is a significant increase over the past 5 years. We have a significant increase in our proactive management of babies that are born very preterm. So those babies that are now born at 22 weeks, we actively manage about 30% of those cases compared to only 7% about 5 years ago. And we have seen nationally a significant rise in planned caesarean section rates for a number of reasons. Across the maternity and neonatal services, we provide a positive contribution to prevention in terms of healthcare. We support smoke cessation services. We have a very active perinatal mental health service. To give you an idea, around 1 in 3 women experience mental health problems during their pregnancy, and we support about 10 to 12% of women during their pregnancy with mild to moderate, moderate to severe conditions. We have a very proactive immunisations programme and screening programme across maternity and neonatal that's important to be aware of. We work with our voluntary partners such as the Live Well Dorset in terms of healthy weight support. We've invested considerably over the past couple of years in our service user voices model, and I shortly will introduce Rachel. And just before we show the patient story, two terms that I just wanted you to be aware of. You'll hear the lovely lady in the story talk about SCBU, that's our specialist care baby unit. And you'll also hear her talk about a condition called placenta previa. It's a complicated condition where the placenta covers the entrance to the cervix entrance, essentially. It's associated with high risk of bleeding for the mother and morbidity and mortality for the baby. And I absolutely have the pleasure of introducing Rachel, who's our Maternity and Neonatal Voices Partnership Lead. We work very closely, and Rachel's a strong advocate for our women and families in Dorset. So, Rachel, do yourself.
Thanks, Hannah. My name is Rachel Filmer. I've been involved in Dorset Maternity and Neonatal Voices since 2017, when my own twins were born. Initially, Maternity Voices was gathering a bit of service user feedback, bringing it to a meeting and sharing some stories. But over the last 7 years, Maternity and Neonatal Voices have become embedded in the way that our services operate. We sit at a more senior strategic level and have input into the development of our services. And what I've tried to do recently is start to gather some videos from some of our families about their experiences, whether good or bad. This particular service user contacted us around International Day of the Midwife because she wanted to talk about the incredible continuity of care that she had from her midwife. And we know that continuity of care leads to much better outcomes for our service users. So I will let her explain it because she'll do a much better job. Thanks.
You know, I was fortunate enough to have a midwife called Rachel. I met Rachel when I was pregnant with Livy, probably about halfway throughout my pregnancy. She was actually a student midwife at this point. I remember meeting her at the GP surgery, but she then maintains sort of like the continuity after that first meeting. Because she was a student, she was always with my allocated midwife, who again was an absolute dream come true. She literally was like an angel, Claire. And then so I had something called cholestasis with Livy, so I was sort of quite closely monitored. And I remember one appointment with Claire. I was 37 weeks to the dot. I said to Claire, "Oh God, I feel a bit funny today." She did my usual checkups. And she sent me the DCH, and I remember texting Rachel saying, "Rach, I'm being induced. Like, what's going on?" And Rachel actually then contacted the ward and said, "I'd like to be there for Kate. Like, I've cared for her throughout her pregnancy. Can I come on shift?" And she did. Rachel started her shift on the Thursday at 7:30, the early shift, I guess, and my daughter was delivered at 7:34. So Livy didn't really wait much, but she did wait for RH. And then somehow, for whatever reason, Liv stopped breathing, which, I don't, it is pretty scary. I remember it like it was yesterday. I can feel like it was yesterday. And I remember seeing Rachel's face sort of look at me, mum. My mum was there at the birth, my partner, Gary. There was just a look in her face, and she pulled the crash bell, and then obviously the whole world and its mother was in my room. Everyone was there, and then she cared for Liv, as it's just it's difficult to explain. It's just the way, her bedside manner, which as a nurse myself, I know how important communication and bedside manner is, especially with a mum that is just watching her baby be resuscitated. And after it happened, Liv was absolutely fine. She didn't need SCBU. It was just her being dramatic after the birth, which has carried on until her now. And then there was little things like that Rach did for me. She ran me a bath, and Gary cared for Liv, and she was just sat, bless her. I was sat in the bath, and she just sat, not using the toilet, obviously, but just sat on the toilet and sort of helped me wash because I just was sore. She helped me do my hair. She helped me get some nice photos with kids. God, I only have one then, with Liv and Gary, and you know, little touches that meant a lot and that you don't forget. And then she maintained contact for I can't remember, they're only allowed, is it like 28 days or something, the midwife? And she maintained that for the whole 28 days because, I mean, the baby blues hit pretty much straight away. But it then sort of turned into a bit more than baby blues. I was incredibly depressed. It was a really, really hard time. I think the trauma of watching what happened with Liv probably hit me more than I thought. But due to my mental health, we decided that was that. We're having Olivia. You know, we've got a happy, healthy baby. And then, this is the next story. I was on the waiting list for an umbilical hernia surgery. And there I was, ready to go into theatre. Did a urine test, which they didn't tell me what the urine test was for, but I just thought, oh, you need it because you're testing for something. Obviously, they didn't tell me it was a pregnancy test. And 3 nurses ran in as I was stood up walking into theatre. 3 nurses ran over to me and said, "Miss Summers, sit down, you're pregnant." And that is how I found out I was pregnant with Henry. And that was that. So I contacted Rach that day and said, I think I'm a lot further gone than think, you know. I want to scan like now. Like, it was a Friday. I said, I want to go back to the hospital now. And she, obviously that wasn't going to happen, but in my mind it was. And she was like, right. She was just fantastic. She managed to get me a scan the following week, and I was very much pregnant. And then I requested that I have Rach for my care for Henry. I think, given what I went through with her, with Liv, obviously I trusted other midwives, but I had that bond with her. She was there. She caught my baby, my first baby, and then she then resuscitated her. And I think that gives you a special bond with someone. You know, she's been there for the hardest part of my life at that point. And she was more than happy to. She got the ball rolling with everything, referred me to perinatal. So I was then under the perinatal care for my mental health, which obviously as a specialist mental health nurse myself is quite interesting feeling. However, it is what it is. You know, I knew I needed that care, so I got it. And then Rach just was there every single step of the way. I had a lot of meetings for my mental health and for my physical health due to like other issues. And, you know, Rach attended them. She came in on her day off just for my perinatal pre-birth meeting. She was in her uniform, you know, she was professional. She was everything you wanted in a midwife. Because obviously I had placenta previa, I was quite a high risk mum. And again, she put everything in English as well, which was really, really helpful. Because when I first got diagnosed with placenta previa, I met a midwife, and she didn't do anything wrong by no means, but she explained placenta previa. I was in this tiny little box room, women's health, and then you know you got placenta previa, you'll probably have a C-section and your baby might be early, and that was it. I was sort of sent off, and off I went. And I thought I wasn't aware of the risks. She did say you might have a couple of bleeds, but didn't say anything about what they would be like or anything. So I was not aware of how unwell me or Henry could potentially be until I spoke to Rach, and she like I said, she put it in English, and that's what you need, because I'm a mental health nurse. I'm not a midwife, so I don't know. And she did, and then I thought, oh my goodness me. Again, that set my mental health off probably even more, because I thought I didn't want a C-section. I didn't have one with Liv, so but I didn't have a choice. That isn't due to anything else that is medically. I did not have a choice. There was no way I was going to have a natural birth. I then obviously had multiple meetings, and Rach, like I said, came to all of them. Yeah, so they planned my C-section for 36 weeks, and it was Rachel works set days, and it was a day that Rachel doesn't work, and so she said, I'm not being there for your birth. So she booked to come in and do the birth, which obviously was amazing. I didn't want anyone but Rach. However, I then suffered probably the most horrific bleed ever in my mind. Sadly, my daughter Liv was there, saw absolutely everything. It was just me and Liv at home. At 7 years old, she rang next door herself to get help. She was amazing, absolutely amazing. She then started cleaning my stairs because there was blood everywhere. She knows that Mummy doesn't like mess. That's my girl. And I got to the hospital and was told I was having an emergency cesarean there and then. I rang Rach on her day off, lucky her, and she said, I'm on my way and coming in. And I told her she's not. I said, no. I said, it's a Saturday. You're with your kids on the beach. I'm not letting you. I've got to do this by myself. At that point, I must have been 34. I said, look, I'm 34 years old. I've got Gary with me. I've got to be a big girl, and I haven't really got much choice. I did, because she was pretty much getting in the car, but I said no. And I gave birth at 34 weeks. And I didn't meet Henry till the next day, and he was in Skaboo. Spent 2 weeks in Skaboo. Rachel did come in the next day. And I've got a beautiful photo of her meeting him. I can't remember if I sent it or not. And honestly, like, you can see the emotion with Rach when she was holding him. She just looked at me, and she wasn't crying, but she had tears in her eyes, and it was just so emotional when she met him. It was absolutely amazing, but emotional. And then she went on a honeymoon, and then discharged me when she came back. So what I have to say is, as you can probably tell from my story, that the continuity of the care couldn't be any more appropriate. Because of the continuity of care, my needs were met. And I feel like, and as you can tell, again, you can see how passionate I am. Without that continuity of care, I don't think my mental health needs would have been met. Therefore, I would be the mum I am today. I know I'm a good mum. I know I am. My children are my life, they're my world. And I think, had my mental health not been stable, I don't think I would have been able to do that. And I think because Rach was on it, stayed with me that whole time, due to that continuity, everything fell into place. And it just makes all the difference to everyone. And I think it meant, because Gary, my family, knew that I had Rach and that continuity, they were again settled, so they were able to sort of relax a bit more, and just meant everything, really. Yeah. I think what I've been through, just, it was horrific. Altogether, I had, I think, 8 blue light ambulance rides. One of them, Rach was with me in one of the ambulance admissions. All I was worried about was my hair. So, I'm sat in an ambulance, and it's 3 o'clock in the morning, and she sat in an ambulance behind me on the bed doing my hair for me. What midwife, and I just think, these women, and I even had a man at pool, are worth their weight in gold. They not only saved my life, they saved both my children's life. And what more can I ask from someone? Yeah.
Yeah, thank you so much for listening. I think we were going to open to questions if anyone had any. Happy to share any information about what we do, but thank you very much for listening. I know Kate's going to be absolutely thrilled that you got to hear that, so thank you.
bringing that to the board today. I guess the obvious question in my mind is the importance of continuity of care came through really, really strongly in that story. How easy do we make that as a system, and what could we do better to create the kind of environment where that can happen?
Yeah, it's not easy, and I think we know a few years ago there were national standards set around continuity of care, which were then withdrawn. So it was seen as a priority for a while, and then other priorities took over. We do have fantastic continuity of care teams at both trusts. And we've just had the 1-year anniversary of one at UHD, who work with our global majority families in and around Boscombe, and they're doing absolutely incredible work. I know more service users would like to have this, this type of care. It'd be really valuable for them, but obviously before, during and after birth, it's very difficult to provide that level of continuity for our staff. So Hannah, do you want?
We have always strived for continuity of care. From an evidence-based point of view, the outcomes are significantly better for women who receive continuity of carer. It featured in all of the national inquiries, but the truth is it's an expensive model to deliver. And when we have faced significant staff shortages within maternity services nationally, it was parked as being able to deliver that. The truth is we still struggle with safe staffing standards in maternity. We're better in the south than we are in the north of England. But we need our units to be safe staff to be able to do it, and what we've been doing is more of a tailored approach, as Rachel said, with the women who are at greater need.
Rhiannon?
Yeah, thank you both. It's a really fantastic example, isn't it, of helping a user of the services to feel safe, and continuity of care totally echo in terms of the evidence base, but in reality it's a challenge. My question was slightly different. So obviously what did come through in this particular story was the ambulance service. The focus wasn't on them, understandably, because the focus was on continuity of care. However, there are going to be occasions, aren't there, when they have to play a role, they have to intervene, because a Rachel won't be there on every occasion. And obviously their exposure to these kinds of maternity emergencies is much less. So I just wondered what work is happening in partnership to upskill their confidence and competence levels in terms of.
So from a maternity point of view, they do community simulations jointly with our ambulance services, and they've been quite successful, and we've worked on shared protocols for categories, and also we input into the pathways and guidance for 111 and for SWAS services around support. That has come out at sometimes from national investigations, actually, that needed strengthening. We're really pleased that SWAST in the Southwest region has now got a maternity lead in it that proactively is involved in cases that involve maternity, and the education and the training. I think there's still more work to do in that, and London definitely led it in terms of having a senior consultant midwife as part of their service. But we are now better on that journey in the Southwest region with Amy, our SWAST lead.
Thank you. And the model that you just referred to, I'm aware of that in other parts of the UK as well, and I think it is definitely a model to think about, isn't it, in going forward in the future. I just wanted to thank you, Hannah, as well, for your leadership in this space. It's been excellent. The progress that's been made in terms of moving us to a much stronger, firmer footing absolutely speaks to your leadership, but obviously how you collaborated across the patch, really. So thank you.
I've got Dan, then Dawn, then Rachel on the screen. So Dan.
Well, I'll echo what Rhiannon said, and Sam stole my question about how to systematise some of these really powerful stories. So I'll ask on a different kind of vein. In terms of the Rachels of kind of midwifery and the stuff going on in the national press, can you give us a sense of morale, recruitment, retention, how it feels out there for people doing this work? And if there's anything that we as an ICB could do pragmatically, realistically, to support that and to improve that. So I'm interested in how the staff feel.
being a midwife myself, I think we've had a significant change over the past sort of 10, 15 years. And make no mistake, it's been difficult. We have lost very good midwives across services because of the national pressure that we have faced. We have gone from a service which women and families love and cherish, and women aspire to do, to being the source of quite a lot of negative media. We have seen that impact in many ways in terms of our midwifery services, but not just midwifery, our obstetric teams, our neonatal teams, everybody associated with it. We have seen attrition and turnover rates for both learner programs and our staff increase. We have seen quite significant changes in terms of morale and feedback. For Dorset, that picture has turned around quite a bit, actually. And that's due to a number of people, including the work that we do in the LMNS. I mean, we're very privileged to have Dawn here. Dawn, as an exec within DCH, does walk around, speaks to the staff, hears what they've got to say. And that's really important at this time, and will be continuing to be important. It's a difficult one. I think, yes, it's great they've launched a national maternity investigation. That feels very harsh, but I recognise in the current climate that we're in, the silver lining to that is it keeps the momentum and the focus on maternity services at a time when we need it. Because we've just turned around green shoots. I mean, for decades, we have been significantly short of midwives in the UK. This report will show the same, because we are still short of midwives in the UK. But now we see people not wanting to come into the profession, people leaving at the point that they qualify. We are the one profession that seems to come out less and less with people qualifying and staying in the job year on year. There is some turnaround for our obstetric and gynecology colleagues. During COVID, they were third in terms of the highest rates of stress and burnout for all medical professionals. It's been a decade of difficult times. And whilst we were a profession that, you know, our wards would be full of thank you cards and flowers and gifts and appreciation, the expectation has risen, and complaints and pressure have risen with that. And we haven't got the services to meet what we need nowadays. The ask for the ICB is to hear when we need safe staffing standards for maternity and neonatal, because they're not easy to deliver across the footprint for the increasing ask that we've got. From a national perspective, we need to recognise that midwives have constantly filled the gaps of other services. The reason that we've got perinatal mental health services where they are is because initially we didn't have the services in place. We filled some of the gaps for primary care. They're under huge amounts of pressure. You know, everything comes to maternity because actually, from an evidence place, we are the one opportunity in a woman's earlier part of their life to make a significant change to their public health and their population health, because we have such great intensive involvement with them. But to do that, people need to recognise we're a very small service for the breadth of what we deliver, and sometimes that voice doesn't get heard enough because of it. I don't know if you want to add anything to that, because you work very closely with our midwifery colleagues and our maternity.
Yeah, I think it's service users generally understand the pressure that the NHS is under. So you get some service users who have quite low expectations and then are surprised when they get really good care. And then you get people who you know, because of all the media coverage and everything else, they don't trust maternity services. Honestly, they don't. And so that's why we're seeing an increase in things like free birth and people avoiding antenatal care. Obviously, home birth is a fantastic, incredible thing that we support, but there are an increasing number of service users who decide not to access any maternity care, and that's obviously very concerning. Hannah mentioned the increase in number of cesareans, of elective cesareans, and the reasons behind that are vast, but definitely a factor in that is people's increasing fear of birth and whether they will get the care they need and whether their partner will be able to stay with them and all of these things. And so what I've seen is the kind of midwives want the best for our service users, and service users want the best births for their service users. And when that happens, everyone's happier. The problem is getting to that point, and I think the inquiry could inflame that slightly and make staff more anxious, but I'm hoping that it will come out with some ways that we can actually improve that trust and that relationship, because it is better for everyone when people feel happy with the care that they've had for staff too.
Thanks, Rachel.
Thank you. And I'm going to build on the topic that Dan introduced. Thank you so much for sharing that incredibly powerful story. We've talked about continuity of care being an expensive model. It's also expensive in the toll that it takes on our staff. Tell us a little bit about how we look after our staff in Dorset. So we talk about safe staffing, and that's very clinical, isn't it? We know that we've got to get that right. Even with safe staffing, this is an expensive toll on the well-being of our staff to provide the level of care that was described in that video. Just can you expand just a little bit on how we look after our staff and where we could be doing more?
So in terms of how we look after staff in that space, there are various different avenues for staff to seek support, both personally but also routinely, that we deliver within maternity services. So we have professional midwifery advocates that are, so every midwife is allocated a professional midwifery advocate. They're there to support them through their professional journey. They offer debriefs, they offer developmental support or training support, but also they offer that psychological and emotional support, and they are there. They replaced the NMC model of supervisors of midwives when that change happened. We also support our continuity of care teams with clinical supervision, and that is recognising that to provide that level of intensive support to women, actually you have to be able to remain a little bit objective, and you can hear some of the battle with that probably in terms of what Kate was sharing with her relationship with Rachel. And so that clinical supervision is really important in terms of managing that emotional ability. Birth is an unpredictable event. I know that sounds funny to say that, but actually we must remember that it's still very unpredictable despite all the risk management and safeguarding that we efforts. We either don't see what's going to happen or something goes wrong, and that needs a much more intensive support. So everyone in the maternity unit, including the executive team, will know when something has gone wrong with the maternity unit, and the first and foremost response to that is absolutely the woman, but also has the staff got the right support. We often put an immediate debrief plan in place, and we wrap, be it the educational supervisors around the medical colleagues or the PMA support, the line management support around those people, because we know that they take those incidents home with them. And we know the profound impact that can have on people, and that stays with people for the whole of their lives. Having worked with midwives, worked with doctors, our practice is unbelievably shaped by those incidents, and they come back to work and they have to do the same job. They might be in the same situation the following day. And that's in addition to all sort of normal line management and the education and training support. There's been a huge amount of investment in education and training support for our maternity colleagues to try and make sure that they're at the top of their game. We have really developed that educational support, and with the help of our with Rachel in our maternity neonatal voice partnership, we try to inject women's feedback into that. We make many opportunities of the celebrations to really try and put some positive stories against some of the negative media. But also there's been national funding that's come down from the inquiries to help invest in certain aspects. So I'm very grateful to the ICB board in terms of approving us to continue the work with our maternity support worker development programme so that people are able to do their jobs, or our student learner champions that we've got in place to hear the voices of students and understand what we need to change about that. We've done great work in terms of embedding the learner voice, because they're a measure of culture, but also they're our next generation of our workforce. So I think it's multifaceted, Dawn, if I'm honest with you, and it needs to be responsive, but we are definitely seeing the benefits. We've got one of the lowest turnover rates now for our staff in Dorset in the Southwest region, and nationally. Our staff surveys, we see them at our local maternity neonatal system board. I know that goes up to the ICB board. Shows really positive improvements in our staff survey results. It shows areas of improvement as well, and that is equally important, because that means that our staff are feeling psychologically safe to say what they need, and that helps us move that forward. So still work to do, undoubtedly, and I think the next few years are going to be again a little bit of a difficult time, but because we have the national investigation, we also have the Thirlwell inquiry coming out for our neonatal colleagues, and we also have the next phase of the Ockenden inquiry due out next year. So some ongoing increasing focus with positives and negatives.
Thank you for that. We've got Rachel, then Louise, then Dawn. So Rachel.
Thank you, Rachel Partridge, Acting Director of Public Health and Prevention. Just wanted to take the opportunity to say thank you. I've had the benefit of being part of LMNS board over the last couple of years and really powerful. So I wanted to take the opportunity to acknowledge the impact that Rachel and the Maternity Voices brings into those meetings, and you will have experienced that this morning in terms of really bringing that patient experience, hearing the voice of women and their families as part of this really important pathway and opportunity, and also taking the opportunity to say thank you to Hannah as well in terms of all of her leadership. You'll have heard that it's a really significant opportunity as well. This is when women and families have contact with health services, and that shift towards focusing on early intervention and prevention. So it was mentioned in the introduction around the smoking cessation and support for women and families around smoking cessation during pregnancy, really important. And I thought it was a good opportunity to highlight to the board some really strong performance figures by the Dorset system. So we are the region in the southwest, or the area in the southwest with the lowest smoking at time of delivery, 5% of women, still 5% too many, and we know that that's a really significant impact on the health of women and babies, but just a really important opportunity to highlight there's some really good, strong indicators of performance when we're thinking about that focus on early intervention and prevention and taking the opportunity to support women and their families to be as well and welcome babies. So a real note to that, recognising that there are often challenging circumstances and pressure, but it was that opportunity to highlight that. Also the work on the inequalities and supporting those women and family that are more vulnerable or need increased level of service, and there's really strong work that's been going on through LMNS, which I'm sure you've heard about here, but just wanted to acknowledge that as well in terms of those frames of reference that are writ large in the 10-year health plan. There's some really good examples that can be drawn out as part of the work through LMNS, and so as well as thanking you for a very powerful start to the meeting and recognising patients, women and their experience, it felt like an important signal to be able to highlight some good practice as well for the board.
Thank you very much, Rachel. Louise?
I think that's right. Is it? Yeah.
Yeah.
Thanks. Again, the video is really powerful, and I should express an interest actually because Healthwatch Dorset team and the Maternity Neonatal Voices Partnership are employed by the same organisation. But I wanted to give Rachel, really, you've spoken a bit more about how important it is to have a kind of an independent group gathering views from parents about their experience of maternity services. So I just want to give you the opportunity to talk a bit more about how the team work, because I think it's really important the way the team's been kind of strengthened over the last few years and much more importance given to that independent voice.
Yeah, sure. So previously, before November, I was sat under NHS Dorset, but our service was outsourced to a local CIC called Evolving Communities, who host Healthwatch and several other maternity and neonatal voices partnerships within the Southwest. So we are independent and external at this point, even though the funding comes through that way. And I have several other MNVPs, as we call them, in Cornwall and Devon and Somerset, who I can work closely with and share that work with. So I think it's really, really positive to have that actually. And I've been doing this quite a long time now, and I'm quite confident telling people what I think. But it is more straightforward to do that when you are external and you feel that you can have that autonomy. So I think it's really important. And we've raised over the years many things that we've then gone on to address and I think really make things better for service users. But there's always more that we can do. There's never enough time, I think, is what we say, isn't it? There's always another project to get involved in. You know, just yesterday, the other two members of my team were running a focus group for UHD for their birth preparation classes to find out what information service users need. And it's all quite time consuming work, but it all feeds into the system and really helps develop services that are actually what people want, and make sure that their care is personalised. And we can't have continuity of care for everyone like that. I wish we could, but we can make sure that care is personalised to those families and what is important to them, because that is different for everybody. So that's really important to us. Thank you.
So thank you. My name's Dawn Dawson. I'm the Joint Chief Nurse for Dorset County and Dorset Healthcare. So I just wanted to build on what my colleagues have said. And from a provider perspective, there are lots of opportunities for us to hear the voice of our midwives and of our users of our services. So, for example, as a board safety champion, I do regular walk-arounds with my non-executive colleague. We'll go around the unit, we'll talk to the staff that are on duty, we'll talk to the women and their partners to find out sort of the feedback that we get from them. As well as that, we attend some of those kind of quadrumvirate meetings where you've got all of the different professions there, again, to hear from our staff what's going on. In terms of things like safer staffing, that's something that's frequently on our agenda. It is reported at provider boards. We're always thinking, do we have enough staff? Are we safe? Is there anything else that we need to do? And I would say I've been in post in Dorset County for a little over a year now. And actually, the feedback we get from the staff is incredibly positive. People enjoy working in the service. They feel well supported, absolutely recognising all the things that Hannah said about some of the external pressures that come on us, you know, from some of these major inquiries. But I think in Dorset, we're actually really fortunate that we have 2 strong maternity units and we have staff who are hugely dedicated. So finally, I just really wanted to add my thanks to Hannah, because Hannah certainly supported me when I came into my role first and has helped really improve the quality of care that we have across Dorset. So thank you, Hannah.
Can I just say, unless there's anything else, can I just say, oh, sorry, Pam.
Sorry, not so good at this bit of things. I've got a new role, so I unfortunately will be leaving NHS Dorset. In September, I'll be going to join the Royal College of Midwives as their Chief Policy Officer and Deputy Chief Midwife for the UK, and take a lead role in influencing national policy for midwifery and maternity services. And actually, I suppose, Dan, to your question in terms of the ICB, the ICB and the system, you know, we've worked really closely with Dawn and providers, and I think that's been testimony to the success that we've done in the past couple of years. Not just by leadership, it has to be a collaborative effort. We need to be very mindful of the risk that faces us in terms of the changes to the ICB and the cluster arrangement. Dorset has been through a significant amount of transformation. We've had an inadequate and a requires improvement CQC report. Somerset are in a very challenged position, and then we've got BSW in the north of the patch. Salisbury's not long come off of a programme. Bath is very good, but we need to make sure that we don't lose the focus on maternity and neonatal across the ICB as a cluster, because actually that could be a strength going forward if we pay attention to it.
Thank you very much. I mean, it's been a really interesting input from you. I thought the personal story was very powerful, and obviously the board was extremely interested in everything you had to say. Thank you very much for all the work you do, both of you. It's an example of good practice for all of us. And thank you for coming to present to us this morning. Thank you. Yeah, and congratulations. The next item on the agenda is the chair's update. You may have noticed by now that I'm not the normal chair here. And in fact, the normal chair is Rob Whiteman, who is on screen today because he's at home with COVID. So I'm going to pass to Rob then for the chair's report.
Thanks very much. Hello, everyone. If I have a coughing fit, forgive me. The weekend before last, somebody said to me, I've had a cough for a couple of weeks, but I'm sure I'm not contagious anymore. And I really came down with COVID. So I thought today I'd be responsible and not be in the room with you, even though I am on the back end of COVID, and I'm probably not infectious, but I don't want to take out the Dorset public sector. And for everyone online, there's no evidence that COVID can be spread by teams. So I think everyone is very safe. I have a few things to brief on as an overview. First of all, Patricia's not here today. She's attending a funeral and for a family member, and I'm sure we all send condolences to Patricia. Siobhan and Matthew aren't here because there's a national chief execs event on the issues that are taking place within the NHS. So I think, you know, just to log that we understand why our chief executives aren't here today. Since the last board meeting, we've had the comprehensive spending review, relatively kind to the NHS. So lots of public services saw flat cash or saw a reduction in cash, and the NHS was relatively well treated. And indeed, some of the wider determinants of health that impact greatly on people's lives and health, such as housing, social housing, fared well in the comprehensive spending review as well. And so I think it's good that the NHS, as much as was done as possible to support the NHS. Obviously, the trusts are now thinking about the resident doctors' strike, and pay issues are looming. And I know I spoke to the chief execs, the provider chief execs yesterday, and I know that a lot of planning work is going on. Nationally, it would appear from the media and commentators that the government is in a difficult fiscal position. Some of the savings that they probably baked in order to announce the comprehensive spending review have started to unravel a little for them, and those savings are not as baked in as they thought, and we've seen welfare reform and PIPs affected by that. And it's speculated in the press that where the government is thinking about changes to SEND and perhaps changes to the uptake of EPHCs, that perhaps there may be some backbench fears about that too. So I think we should be pleased for the settlement that the NHS has, whilst reflecting that there will be pressures, and we see pay raising its head again, and that actually for the rest of the public sector, the government is probably in quite a difficult position because some of its reforms are not as baked in as it hoped when it set the review. Of course, the other big event has been the 10-year plan. We'll hear about that during the agenda. I think just step back and think about the scale of change. The 10-year plan sets out a vision that neighbourhood health centres serving a population of roughly 50,000, led by GPs, with more diagnostics and more clinics and more access to mental health, access to local authority services and the voluntary sector, that we create neighbourhood health centres. And if you think about the numbers of organisation at the moment, it's interesting that whilst we're clustering ICBs, local government is being reorganised in two-tier areas, and the government is looking for local authorities of around about 500,000, 500,000. And if you put that together with the 10-year plan, is looking for neighbourhood health centres of 50,000. And actually, for many of our local authority areas, and the 6 local authority areas of the new cluster that we're forming with Somerset and BSW, then we're going to be looking at 7, 8 neighbourhood centres, and they don't, on the whole, exist at the moment. Although there's some really interesting pilots that have taken place, and but on the whole, the new role for ICBs will be to commission contracts in a way that leftward shift of hospital to community and treatment to prevention and more use of apps and IT, the ICB's commission contracts in a way that leftward shift takes place, whilst at the same time there'll be a big focus on ensuring productivity. And you would have seen Andy Haldane, for example, is developing a productivity index for the NHS. And before we talk in detail about that, it's just worth reflecting on the scale of that change that will take place over the next decade, and at the same time, the development of integrated health organisations where trust can be at the heart of creating, with GPs and other providers, that new approach to neighbourhood health. And I'm sure we'll see the development, the need to build the capability of GP consortia to be able to be the anchor of neighbourhood health centres, and also develop and mature trusts in order in time to become integrated health organisations. And so the role for the new ICBs is one of developing the capability to move to a more strategic approach to commissioning, which over a 10-year period addresses that. And we're certainly not about to make decisions on that, are we? But we're about to have an awful lot of conversations and talk about what that will mean, and how do we deliver it. For the clusters in the southwest, you'll remember there'll be 3 clusters: Devon, Cornwall, and Gloucester, and our new cluster with Somerset and Bath, Swindon and Wiltshire. We're expecting chair designate appointments for the clusters to be announced shortly. Nothing to say on that today, other than the process of chair appointments is in hand. And after that, the appointment as soon as possible of chief executives for designate for the clusters, in order that we can put some acceleration into that. And I think together there will be the need for a short-term focus on how does Dorset ICB and its partners deliver this year's operating plan. You'll remember that we have high ratios of SIPs, cost improvement programs, within our operating plan this year from the trusts and indeed from the ICB. And so somehow we must make sure we don't drop the ball in governance terms, and that we stay on top of the delivery of this year's operating plan. But then as the cluster develops, we will start to think through formation of a cluster board, and what do we do jointly, and all of that to be worked through, as well as a new chief executive thinking through what the organisation will look like. My personal view, and these are personal views, is that it's important for the new ICB cluster to ensure that where we are making reductions of 50% in order to slim down the amount of resource that's deployed, £18.76 or 20 quid, call it when you round it off, per capita. It's really important that 13 or 14 pounds of that is spent on strategic commissioning, and the capability to deliver all the things that I've just said will be required of the ICB to lead and deliver over the course of the 10-year plan. And so in the coming weeks, as we get more news on cluster development, and we have a joint transition committee next week, then obviously we'll say something. In the meantime, we plan to streamline our own governance to 3 main committees. I'll say more about that when we get to the item later on the agenda. And whilst today we'll talk about our interim governance within the ICB, I think, Kay, to you as chairing today's meeting, if there is time for a wider discussion about, so what does future governance, how do we make sure local government is involved? How do we make sure partners and everybody is involved in the development of future governance? I think it would be good to hear some voices on that if we can fit into the agenda. And Sam Pro and Nick Ireland kindly let me know that they'd like to give some thoughts on that. I hope that's a helpful overview. The interesting thing is, whilst we don't have the capabilities to do strategic commissioning yet, how do we go in the right direction? Paul Johnson and I have been meeting GPs recently, Paul, about phlebotomy and the difficulties of GPs providing phlebotomy potentially at a loss. And so actually, through our commissioning intent, we will want to see more money go into GP phlebotomy, but that will probably need to be decommissioned from someone else because we've only got one envelope. And so I think the point I'm making here, whilst using that as a very small example, is there are things we can do to go in the right direction of the 10-year plan. And it's good that our new commissioning committee will think about things like that. But obviously, much of the heavy lifting about how this will work will be developed through the cluster and the new arrangements for as we build a new cluster and a new organisation moving forward. My final point to say is the public sector at its best is, you know, when we all get behind change and we all enjoy delivering it. We all probably think the public sector at its worst is when everybody's at everybody else's throats. And, you know, over the years, I saw many unfortunate, you know, tensions in parts of the country between PCTs and providers, or between providers and local government, or between all the people I've just mentioned in the community and voluntary sector. It is absolutely essential, if we're going to deliver the 10-year plan, that we work together and we are a team with common purpose to do what's best for the public. And the exciting role for ICBs will be to make sure that we have population health analytics, that we think about the needs of the community, that we have the tools available to people as engagement architecture changes, which we also saw in the 10-year plan, and of course ICPs themselves coming to. And so a great discussion to be had in the months and years ahead about how we develop that future state. But I hope an overview at this stage, Kay, of where we are and where we are in the development of cluster development. I hope all of that is helpful to set the scene for the rest of the meeting. And I said all of that without a coughing fit. Yay. And I'm very happy to take questions, Kay, or we can move on to the Chief Exec's report.
Yeah, the issue of the cluster arrangements are coming up in part 2 this afternoon. So I wondered if we could leave the discussion about the local authorities' involvement in that until part 2. I'm very aware of the agenda for this part of the meeting is quite tight and we're already over. So are there any other questions or comments that you want to raise with Rob about any other issues that he was talking about there apart from the cluster issues? Nick?
There you go.
Press the left-hand button, you might even get on camera.
So
then press
do I need to be on
button,
camera? I don't want to be on camera.
That's it.
There you go. I mean, it was just a comment about, was it 50,000 in terms of unit? That, you know, I was just thinking about the geography of Dorset. That is pretty much the town of Dorchester and everything going west to the border. If you exclude Sherborne, you get 50,000 odd. That's a huge area with no meaningful public transport at all. So I'm not quite sure how that's going to work. Just a comment.
Well, we need to, I mean, it's going to vary so much because this has got to be put right locally. And so I think we have these blueprints, Nick, but obviously localities vary considerably, and we need to use the blueprint as a way of building something sensible, in my view.
I guess I was just going to build on that, Rob, because the 50,000 has been quoted for a number of things that we've had to implement over the last few years, whether that be PCNs, integrated neighbourhood teams, and now neighbourhood health centres. And we've always been able to design what that looks like on our geography, and it has been very different for conurbations as it is for rural. So I would either expect that flexibility to come, or there is an onus on us to create it.
Thank you.
Sorry, Forbes, yes.
Okay, thanks, Kate, and thanks, Rob. I fully support your comments, really, about this time of change. And I think it's really challenging, but I think the 10-year plan is an opportunity for Dorset. I know my GP colleagues are, I don't want to say enthusiastic about it, but certainly embracing the concept of the left shift and how we might deliver that. So our geography in Dorset does lend itself to that. I accept the comments just made, but our existing footprints around PCNs cover the whole of Dorset, and while they're not all at 50,000, some are and some aren't. I think there's a conversation to be had as we get the detail, because the plan at the moment is very high level and we need to now get into the detail. I think the other part that hasn't been touched upon is the potential contractual changes or perhaps opportunities that are going to be introduced in the autumn and the spring, not necessarily changing existing general medical services contracts or practices, but introducing new neighbourhood contracts, which we need to, spend some time looking at in more detail. So I think we do need to grasp the opportunity. I've been in several conversations, and as I'm sure they appreciate in the past week, and those will continue. And much ICB support as there can be to do that, because it absolutely aligns with our Dorset ICB strategy.
Thanks very much. Thank you.
Okay, so moving on to the Chief Executive Officer report, which in Patricia's absence, you're going to lead on, David?
Yes, thank you. Thank you, Chair, and colleagues, and apologies for not being able to be there in the room today, and also for being slightly late. I was just working out, I was stepping off a plane about 6 hours ago, and hot footing it, or hot carring it actually, to here in order to sort of present this paper and a couple of other things that are coming up on the agenda. And in fact, between Rob and Forbes, just covered off the kind of main points I was going to make coming into the Chief Exec report, because the important things in here around the spending review and the 10-year plan, they kind of confirmed what we sort of hoped for, what we expected, and perhaps even what we were a little worried about in terms of what's now required of us. And by word, I mean the scale and the pace of the change, but the exciting opportunity within that. I would say that the scale and the scope of the announcements as they've come through and been confirmed do align really nicely, excuse me, with everything we've always committed to across Dorset. The Dorset ICB partners, ICS partners, I've always said that we wanted to build thriving communities, focus and invest on early help and prevention, and find ways of working better together. And if you pick out the critical elements of the 10-year plan, they're all saying those are the things that we need to focus on, and adding more detail to it. So as Rob has said, this creates an opportunity, an exciting opportunity as well. If we can manage the pace of change that's required and the scale of organisational change that's required, then there's a lot to be gained from this, and we have to act in the interests of our local population. And in fact, although I was late, I did hear the second part of the maternity story, and certainly all the discussion that followed. And I think, if nothing else, that reaffirms why we are making the changes we are making, because we want these improvements to come through. There are a couple of things that I would do, Kate, because I'm conscious, as you said, that it's a very busy agenda today, and we've got some items on each of these things a little bit later on some of them. There are a couple of things that I wanted to pick out. Just a correction in 2.1. It says that the increase in the 3-year in the NHS budget over the 3-year period is 29 million. It's actually 29 billion. It is echoed somewhere else and in the paper, but it's really important. That's a very, very big difference. So it's just a typo. Just to confirm, it is 29 billion. But with that comes certain requirements and expectations of us in the NHS, across the NHS, and with our local partners to deliver. I shan't dwell on those because they're well set out in the paper, and we've touched on some of them already. Importantly, within this, it does not remove the need, it doesn't help us with our financial challenge and our need to get on a sustainable financial footing. So that remains one of our top priorities and one of our key areas of focus this year, and as we move over and the legacy transfer into the new cluster ICB. The 10-year plan, so what's really important to note for the 10-year plan, this is what we knew at the time of writing this report. This was done on the day or so after it was published. More detail has followed, further discussion, and I have to say rather sneakily, I did look at the news when I was on holiday to see what was being said about the 10-year plan. I had to do it in quiet because if my wife had spotted me, she would have been very, very cross. But I couldn't resist when I saw the headline pop up. So I do know that the way it's being received and the discussion that's following, as Forbes alluded to, there's a real optimism that this might be the breakthrough that we need to make the big changes that are coming. We have set out in Patricia's paper with Jane's help, we have set out what some of the key elements are, and I think it's really helpful to receive that. There's an awful lot in the 10-year plan, but more discussion, more detail, more guidance documents coming through over the last couple of weeks. So what we got here is what we understood at the time. And then I just wanted to touch on three other things. One is we can't, whilst the kind of a large part of this paper is focused on the spending review and the opportunity and the needs within that, the 10-year plan, the opportunities within that, we are continuing to spend a huge amount of time, effort and energy on the job at hand. We set out into this year with some very strong, clear commitments about what we wanted to achieve, and we're working with NHS England and our regulators to make sure that we're doing that in the way that's effective, is genuine improvements through there, and we're taking a holistic view of that, and part of the role of NHS England and ourselves is abiding by and adhering to oversight frameworks, performance measures, performance standards, quality standards. And a new NHS oversight framework was published on the 26th of June, updating previous iterations of that document. And it will be reviewed again as new ICBs are formed and NHS England merges into a new Department of Health type structure. But for now, it makes it clear that achieving our goals for this year is the top priority. And we're obviously committing ourselves to doing that. And it also describes a new segmentation process, just expanding the categories that are there. Currently, the segments are 1 to 4, 1 being excellent performer, 4 being under national needing national support. There's a further segment added to this new oversight framework, segment 5, which is a much more stronger direction from regional teams and national teams about what individual NHS and ICB organisations need to be focused on. We haven't had our assessment formally through yet, so we don't know what our initial segmentation is under this new framework, but we expect to receive that this month in July 25, and that's a live conversation at the moment. That information, our segmentation and the detail about it, will be made available publicly. The other thing, penultimately, is the UEC plan, urgent and emergency care plan, which is really, really important because this is obviously a critical area of need and demand and pressure across the NHS. And there's a new strategy, a new plan published on the 6th of June to focus our efforts and attention in certain areas. Some of these we're already paying close attention to because we know that they're important. So it's sort of segued quite neatly into what we're trying to do. And also, it's really important as part of our winter preparations, where we know the pressure on urgent and emergency care increases significantly. So trying to make sure that we're paying attention to the new plan, implementing the new suggestions where we're not already doing it, is all part of being well prepared for the year. And I think those two things, of all the things that we mentioned and we talk about today, really sort of underscore the importance of the day job, the here and now. Whilst we're trying to build the change and make change happen, a strong focus on what we're trying to do today also remains, and that's important. And then the final thing I wanted to mention, it's very easy for us to look at this through the health lens with so much going on and so much activity and so much change at such a pace. We do have some brilliant updates in this report. they're always brilliant updates, but some really exciting updates in this report from the local authority and voluntary sector partners. I'm not sure, I shan't go through those because it's for those colleagues to mention them, but I did want to draw your eye to them if you haven't seen them already, because there's some really good developments reported, and it's important for us all to be aware. So, okay, that's all I was planning to say. I'm happy to take questions, obviously, and anything else that people might want. Thank you.
Thank you, David. Thanks for the comment about the other reports with this. And I just wanted to pass my congratulations on to Graham for leading the best performing SLT.
Thank you. It was really good to get that recognition, and the team have been through a lot and achieved a lot. So thank you.
Any questions or comments for David? Adrian?
Let's ask a question about 10-year plan, David. I suppose as an observation, nothing has come to me via our organisations. I've just kind of been on the website and downloaded it the same as everybody else and read it, etc., etc. I don't know how I feel about that. I would have thought that there probably ought to be some comms, not necessarily from NHS Dorset, but from the department that's kind of coming into the organisations that are going to have to execute against it. It might be that hasn't happened yet, but I would just be interested if there's something I haven't seen, and if not, when we might get it. And if you don't know, say you don't know, and maybe Rachel will take it away for us and say, when might we get something? The question on the back of that, rather than the slightly grumpy comment, is how does this then move into implementation planning? Because at the moment, it kind of feels to me as though there's a real risk that, kind of we as organisations that need to implement don't catch it and make it happen. There is, I think, it was referenced in a number of the other earlier comments, including Forbes, that there's a bit of excitement about it. It kind of feels like the direction of travel is saying a lot of the things that we want to hear, and therefore there's a lot of goodwill to mobilise, but I worry that we might miss the opportunity to grab it. David.
Right, I believe Paul wants to take your first question, and then I'll come to you for the second one, David.
That's all right. Cut me off. So on your first question, we were discussing this in executives just yesterday, and what we are planning to do is to make sure that we have some time dedicated as a group of executives looking through the 10-year plan, picking out, so what does this mean as an ICB in Dorset, but in that wider cluster as a strategic commission? What is it telling us that we need to be prepared for, and what are the things that we're going to have to implement? So we were planning to work through that. And then I had a couple of discussions with a couple of people. It would then make sense. How can we then feed that into the board? And is there a space within the development of the board that we can do? So from that, we may well then be able to articulate, this is what it means for Dorset. This was what it means for an ICB, whatever geography that might be at the time. So that's kind of where we got to in our discussions. Dawn, you may want to build on that.
Yeah, just to build on that, thank you, Paul. We need to make sure that our non-executive members have got access to our internal sites, because we have been providing the our wider staff with the updates on the 10-year plan, Penny Dash's report, etc. So I will check to make sure that you've all got access to the information that we are sharing. But what's going to be really important is, as Paul said, the time to spend the time on the plan as a wider board.
David, do you want to pick up the second half of Adrian's comments?
Yeah, thank you. Well, I think Paul covered quite a lot of it, actually, which is really helpful. Just a couple of things I would add. One is, well, the cluster ICBs is emerging. The reason for creating that structure is in order to drive forward this new strategy and this new plan, and the re-engineering of the rest of the system architecture. So by that, I mean, the local providers, NHS provider organisations having to think and work differently, the changes to the regional and national structures, and obviously that commitment to working with the local authority and voluntary sector and community partners coming through policy direction, not just through our strategy and ambitions. And I think that's really, really important and really exciting. And therefore, what we would expect the new cluster ICB to be able to do and be doing is focusing on how we drive forward the needs and the opportunities in this work from a strategic perspective. So looking at the short, medium and long term. I think, as Rob outlined, actually, that is its job, its goal, and it's designed to implement that. And that's pretty exciting. And then the second thing is that, of course, within all of that, we want to make sure, and I think Paul landed on this, which is that we and as we start to come together more as a cluster of 3 ICBs, what is it that Dorset needs from this work going forward? What are the current challenges and opportunities and needs? All the work that we've done to this date actually tells us all of that. So we want that to feature in the work of the new cluster organisation. So we do have a dual role. So one is to kind of make sure, as the cluster is being formed, that it is being formed in order to deliver on the ambitions of the 10-year plan. And the second part is to make sure that it is picking up the work that we want to do, need to do in Dorset to meet the challenges that we've got, and of course to deliver the ambitions of the 10-year plan. So I think to what Dawn said, whilst there's quite a lot of information flying around at the moment, and this much I have picked up on because there's a huge amount in there, it's a large document, there's a lot to absorb, and of all the things that seem important, what are the most important and what can we do first? All that is being worked on. I think spending some time with the board going through it as well is going to be really important as part of that legacy handover to the new organisations that are coming.
That would be really helpful, David. Do you want to come back on that, Adrian?
Well, yeah, there's a risk. It sounds like having the last word, which isn't really the intent. So it's helpful updates. Thank you to Paul and to David. Just as an observation, I think it would be worthwhile just creating a milestone to check ourselves that intent is actually the way that it's working. I perceive a risk that the cluster work will become itself oversubscribed for bandwidth just to create the strategic commissioners of the future, whereas actually 10-year plan is whole system evolution. And I'm not confident, David, that the clustering work will actually be able to achieve what you've just set out. Thank you.
Okay, so I've got Rhiannon, Dan, and then Sam. Rhiannon.
Yeah, thank you. Two things I just wanted to pick up, and maybe one of them does slightly speak to that because I might be increasing the bandwidth with my question. So one of the things that spoke to me in the 10-year plan was that greater transparency piece, and that will really give choice, or it should. The intention is to increase choice for patients in terms of, publishing performance around individual clinicians and organisations, and I don't understand currently what our gap is. What's our starting point? What's our baseline for that? We've got a massive road to go, or are we already doing some of that? So that was one of the things that came through for me, and I think that whole, obviously depending on what services we create or co-create and commission, also lends itself, doesn't it, in terms of whether we widen inequalities or not, in terms of that patient choice, who can go further or not. So there was just that point. And then more in the here and now, I think it was really right, David, to focus on the winter plan. I heard a colleague further in the southwest speak to last year's winter being the worst one they'd ever experienced. So I think the concern being, as we lose people as part of planned reshaping what we need in terms of staffing and resource, but having sufficient people to be able to both develop and deliver that plan over, I know we can't predict, but I think if we base it on last year and previous years, it's likely to come with a number of risks, isn't it?
David, I'm going to ask Dan and Sam to ask their questions first, and if you could take them all together then. So Dan.
Thanks. A bit of a process question. I read this report with a finance lens on, so kind of sorry, not sorry about that, but a few things jumped out at me. I think there'll be real pressure this year for the ICB to focus on this year's financial management. Absolutely right. But I'm mindful of the MTFP. So what's the process for the scenario planning out the £29 billion settlement? I want a bit of assurance that we're not waiting to be given kind of allocations, and we're kind of scenario planning, and how's that feeding through? And then the other bit that I don't think the board's seen a lot of is the business case for the subco for estates. And I assume that's benefiting trust MTFPs, which will kind of come up into the system. So I don't need a particularly numbers answer, but some assurance on the process that as these things emerge, and there'll be a load of known unknowns. What's the process for updating the system MTFP so that we can hand something over to the cluster?
So if we take Simon, then I'll come back to you, Alison.
I think my question might be best taken towards the end, Kate, because it was about the local authority reports and the appendices, and then to kind of set up the discussion in part 2, maybe building on Rob's intro.
David, if you could respond to Rhiannon, and then I'll ask Alison to respond to Dan.
Yeah, thank you. So yeah, the greater transparency and the baseline for where we are and what we're trying to do, that's definitely part of the planning. Rhiannon will be working through. It's actually in the oversight framework as well. So we're being asked to track all that stuff and be ready, readying ourselves for reporting in those ways, and certainly will be part of the new ICB's arrangements. So that baseline work is the stuff we're paying attention to. And the winter plan and the risk of losing experts, you've landed on a really, really good example there. The Southwest had a very stressed winter with lots of demand and quite a few delays and some difficult days, weeks and months in some cases. Dorset was okay. We had our pressures, we had our periods of very peak pressure, but we managed those pressures really well, and we came back into within normal range and normal scope of operations quite quickly once those pressures had arisen. And that came from lots of good winter planning, people who'd worked. And Dean, you might want to be able to say more on it, but worked through Dean's team and through other colleagues and through our provider partners on really robust plans and close working together, and that kept Dorset safe through winter. And then so that's good. So we're paying attention to that. We're going to try and repeat that and build on what the urgent emergency care plan advises us to make it even better still. However, there is that constant risk of losing experts, organisational memory, partnerships, relationships, the informal stuff that we do very well in Dorset that gets a lot of stuff fixed and organised, early warnings, heads up, let's have a brief discussion about that, can fix an awful lot of arising problems. And we might run the risk of not having that available as we go through the winter period. And it's not just winter. I know that you use that as an example, as I'm using it as an example. It's true across many of our disciplines, and it is one of the challenges of change. However, we have noticed that is a challenge of change, and we are building mitigations as best we can for doing that as we go forwards. So it is that kind of difficult phase, isn't it, of doing the J job really well, whilst maintaining the motivation and focus of staff whilst we go through a major organisational change in order to deliver the promises and the excitement and the ambitions of the 10-year plan and the spending review. And that's a balance we're striking to make all the time across the exec team and across our wider partners as well. So it's high on our list of in fact, you'll see it later on as well. It's in our risk report as well. So yeah, thanks, Rhiannon. I think it's more that we need to keep reporting back to you about how that's progressing. I kind of like Adrian's point about milestones. We are committed to this. So how are we demonstrating that to others and tracking it for ourselves in order to make sure that's happening? I think that's a good point as well. Thank you.
Because we've already done the timetable and started the work on winter planning for this year. So the processes are already in place, and kind of that is much earlier than we've done in the past. The processes that we had in place last winter, well, thank you. Just remember I hadn't turned my microphone on, but it was turned on. Kind of the processes that we had in place last winter really delivered well for us, and David's already mentioned. I keep hearing across both systems that last winter was the best we've ever had, or the worst we've ever had. In the Dorset, I would say the 3 years since we've been here as an ICB, each year has got slightly easier, the way that we have done, and that's the way that we've worked together to do that. One of the things that really delivered for us last year was being clear on what our demand and capacity was going to be over the winter. With the work that we've done through the Future Care programme, that's the work that we're doing with Newton, we are now really, we've got such a level of detail about what our health service and local authority services are and the changes that we're making to those, that we've already got in place a seasonal demand and capacity model that models all the way through from the changes that we're making through Future Care to knowing how we take that money out safely through the operating plan, but also what we need in place to see us safely through next winter. So it's the best I've ever seen that the system's done it. And I think overall, kind of the ICB doesn't deliver any of these services. I would say it's our providers and local authorities that are running the service that get us through winter. And it's down to those people that are running those services every day, the way that we engage them. We heard about maternity services earlier, the way that the Future Care programme is engaging particularly our ward staff this year. I have every confidence that kind of things will be even better this year, despite that risk of people changing. And it's the preparation that we put in for it for over the next few weeks.
Thank you, Dean. Is that okay, Rhiannon? Yeah. Alison, do you want to respond to Dan's question then?
Yeah, thank you, and thanks, Dan. So I don't think we're waiting for anything at the moment in terms of what we're trying to do. So there's three pieces of work that would be useful for the board to be aware of. So one is we're working with the national team in terms of the oversight framework. So Chris for UHD DCH it's taken that one on the proactive approach the trusts have brought in to get financial support in. So actually looking at what does the tiers 1 to 5 actually mean and what would happen. So we've got that piece of work going on with the national team. Pete has offered to do some work with the national team on the UHD. So we've got a new performance scorecard that will come out. So we're testing that in UHD to see what that would look like, what would it mean to get ahead of the curve in terms of what that would start to look like. What goes all the way through Patricia's briefing then is around a new financial framework that's been introduced. We'd already started to do a piece of work to look at if we move back to activity-based contracts, what would that look like? What we've learned is the financial framework for next year will be very different. So again, what we've said is actually could Dorset be one of the pilot sites to do some of that work? That will then test in terms of where do we start the medium-term financial plan for September. At the same time, we are looking at is everything we're doing and our savings programme, what does that mean to our underlying position? So that work we've said we'll bring back to the next PPC meeting to see if we're going in the right direction of travel, and we'll test that as we go through the tariff base. So they are probably the proactive bits we're looking at. We are waiting just for the delivery plan to come out on the back of the 10-year plan, because that will be an important bit around what does some of the phasing look like alongside the 29 billion. How will that be allocated over the next 3 years? So there are bits we're waiting for, but then there's the proactive bits we're doing at the same time.
Thank you, Alison. Forbes, did you want to come in on this, or is it another point?
Well, it's another point, but linked to what's been mentioned already.
Right, go ahead then.
It's something perhaps Dean and I can talk about outside the meeting. It's really just a general comment about the winter plan, and I'm really glad to hear that it's gained traction and moved forward. But historically, the winter plan in Dorset has been very acute focused. So I'm just wondering what changes we're going to make this year to look at the opportunities that might exist pre-admission, i.e. outside of hospital, in the spirit of the 10-year plan and our own strategy. And then there's a second point, Kay. So will we respond to that first, or do you want to make the second point?
Make your second point.
Yeah, the second point was just very specifically about 1.4 and the maternity service changes. We've heard earlier in this meeting all about the challenges that are for maternity, and then we've got the changes at UOVO, which it looks like there's been mitigation in place, and Dawn, I'm sure, can offer assurance. But when we previously looked at this many years ago, if South Somerset patients come into Dorchester, that was going to create very significant pressure on the Dorchester service. And the fact that what's quoted here is an additional one third of patients. Now, for any service at short notice, additional third of patients is pretty significant. And I just wondered what the assurance was, particularly around the ability to deliver the safe service for those individuals.
Thank you. Dean, can you take both of those or just the first one?
I'll certainly take the first one on the admission avoidance one, because one of the kind of the 4 work streams that we've got as part of Future Care is admission avoidance, and the way that that's involving primary care and particularly local authorities to turn people around. Take your point, Forbes. It hasn't been very integrated previously in when we've had money for how we deal with kind of more urgent care outside of hospital, and particularly in primary care. But we will make sure that is included this year in the planning.
David or Pam to respond to the maternity issue. Who's going to take that one?
Pam can do that, or Dawn, because Dawn is within the.
I don't happily respond to that. So in terms of the workload that's come across from Yeovil, yes, we did have to change what we were delivering fairly swiftly, but we've got routine meetings in place internally. We've got a weekly conversation with Somerset Foundation Trust, and also the ICB has supported us. So we had a meeting last week, I think, with Alison and Pam, just about the additional resource that we needed, not necessarily midwives, but the broader sort of obstetricians and anaesthetists. So absolutely, we're managing those risks, we're mitigating, and we're delivering a service.
Thank you, Dawn. Sam, do you want to make your comment or question?
Yeah, I can do. It was the kind of invitation, I guess, to talk to the local authority reports, which I'm not going to do in detail because you can read the reports. But I guess from my perspective, I'm sitting here thinking today the English devolution bill is going to be published. You've just had the 10-year health plan. There is a risk that we start to go down quite separate routes and become obsessed with our own language and our own structures as those conversations develop. And already, without going into a huge amount of detail, I think there are tensions in the health plan with the direction of travel. As part of this interim role, I've taken on responsibility for leading quite a challenging change programme within Dorset Council. And I guess my learning from that is just how quickly we talk about structures and we lose sight of functions and what we're trying to achieve. So I think off the back of, the chair's report and some of the conversation we've had around the health plan, I'd urge us to start to think in terms of what are the functions we need to preserve as a system and how are we going to enact them, regardless of what's happening on the national policy front. And I think the conversation we've just had about winter is a case in point. There's a risk that we will just start to think about narrow health service interventions pre-hospital. But there's a whole dimension here around vaccination status of people who work in social care, in the voluntary sector, and all of the work that we did around COVID to make sure that COVID vaccination and flu immunisations were as good as they possibly can be, that I worry starts to fall out of sight when we become more and more concerned with arrangements for commissioning at scale, whether it's clusters, and what councils might be doing in the space of devolution and working at a bigger scale. So it's just a thought to leave with you before part 2.
No, I agree absolutely, and I'm sure that's going to be our job, really, isn't it? Or part of our job going forward. Thank you. If that's okay, I assume that's a legacy hand, Forbes. If that's okay, can we move on to the board assurance framework, please? And I imagine, David, you're talking to this one?
Yes, thank you. And colleagues may want to come in on specific risks if there are specific questions for it. So colleagues, you'll be aware that we've had a board assurance framework in operation for several months now. Before Christmas, we took the view that we wanted to review our board assurance framework and do some revisiting and reworking of our strategic priorities in order to reformat and re-engineer the board assurance framework. And at the same time, we also took soundings and some best practice really from other ICBs and from our auditors about how we might further improve our board assurance framework. We did decide to firstly postpone that work because of internal pressures around our operating plan, and then subsequently overtaken by the national announcements around organisational change and the new areas of focus that were required as part of the new national policy direction, of which we now know much more detail about. And we took the view that actually to spend time against those other pressures and in the backdrop of this is going to have to change anyway. Once a new cluster board is formed, it will create a board assurance framework, which will be based on the strategic priorities and areas of focus that it deems important for our 3 current ICB areas, that it wouldn't be worth our while going into any great detail, reformatting, reorganising and rethinking our board assurance framework. What we did do is agree to maintain the current board assurance framework with the improvements that we've been making every time we go around this, we spot something we can do to improve on it. But we felt that the risks and the issues identified were still pertinent. They're still the right areas to pay attention to, because if we achieve them and sort of reduce the risk in them, we would be making good progress for our partners, for our population, the people we serve, and for our plans that we've got. So this is regularly updated by the leads, executive leads, and it does go through our subcommittee structure for review. So what we have here is the final report that's gone through all the subcommittees and risk and audit, and is presented here for your information, although obviously questions and comments are welcome. But I wasn't going to say anything further other than, if colleagues have, as I said, if there are specific questions about specific risk areas, then I and other colleagues can come in and answer those if helpful. Thanks, Kate.
Thank you, David. We are running almost half an hour late now on our agenda, and next section is the break. So I would ask you to bear that in mind. So Dan, you wanted to ask something.
I'll take your challenge on brevity, Kate. It's 2 comments, not questions. One is, I absolutely support what David said about the pause. We should just keep reminding ourselves that there's a difference between a board assurance framework and a strategic risk register. And I think we're in strategic risk land, and that's okay. But just to make that comment, the second would be, I just question whether we're still intolerant on the ability to transform, given both the financial position and forthcoming changes to clustering. And I don't need a response to that now, but I think for the next board, it would be good if there's an action that we really look at. Are we actually with intolerance? So I'd suggest that risk may be underscored. Thanks.
As there doesn't seem to be anyone else, can we make sure that for the break that we only take 10 minutes? And so we should be back here just after 12 o'clock, 2 minutes after 12. Thank you. Now on to the Integrated Performance Committee escalation reports, and I've asked the chairs of the committees to take the report as read, but to raise any particular issues that they wish to. And the first one, in fact, is mine, which is the Strategic Outcomes Committee. And I think we can take this as read. The only thing I would comment on is how good it has been to have meetings with all our innovation partners there. It really has given me insight into all the work that's done that we didn't used to see before in the board or in any of the committees. And that has been really refreshing and really exciting. So massive thank you to all those partners. And you'll see there on the report all the good work that they're doing. Likewise, on the prevention escalation, oh, sorry, I should ask if anyone wants to raise any questions on the SOC report. Nope. On the PEOC report, the Prevention, Equality and Outcomes Committee, again, I think we can take this report as read. Most of this, the inequalities report, for example, there was nothing specifically new and startling in it. We knew most of what was coming through in the annual report. We were very aware of both the areas of strength and where we're making real improvements, like on CVD, and we were aware of the areas that we still have time to go. And the rest of it, I think, is fine and very well summarised by Liz on the escalation report. Anyone want to ask any questions? Excellent. So I'm moving on then to the quality and experience. That's you, Rhiannon. Safety.
Nearly forgot. Thank you, Kay. I will take it as read, just though to say we received a number of annual reports, the Infection Prevention Control Report, the Leader Report, Safeguarding Annual Report, which was approved to be published, and the Children in Care Care Leavers Report and the Customer Care Biannual Report, and really helpful to kind of see all the work over the year, which was really good progress been made in lots of areas. Obviously, some areas of focus for going forward in thinking about moving into the clustering arrangements. Thank you.
Any comments or questions on that? Thank you. So we're going next one, Dan, to you for the productivity performance.
Thanks. I'll take the paper as read and pull out two things. The committee really focused on financial management and really welcomed the new to the committee flash report and talking about how we'll hit the budget for this year, particularly focused on areas of risk such as AACC. I should spell the acronym out, but I don't actually know what it stands for. All age continuing care, efficiencies, WTE. And so there's a really good dashboard there that will iterate and improve to make sure that we land where we want to land financially at the year end. And the second point I'll pull out is we approved the mental health investment case for children and young people. I put that out for two reasons. I think in a financially constrained environment, it's really good that we can make choices about where we invest in areas of need, and this is one of those examples. But also the team has worked really hard to get to a really good business case that's deserving of investment. And it's been through the committee a couple of times. So I know Dean will pass that on to the relevant team, but I just wanted to put the board's thanks in the minutes.
Any questions or comments? Can I just say the same about the mental health? It was very well done. They responded exactly to what we'd asked for. Because two of them are called PEOC, I thought this was a mistake on the agenda, but in fact the other one is People and Engagement and Communication Committee. So my apologies, Lisa, for passing you by.
Thank you, Kay. PEOC and PEC, it's an easy mistake to make, isn't it? They look the same. So just again, assume that this has been read. It's worth saying, though, that we approved the update on the Dorset ICS widening participation plan. That was a decision made. We also completed the deep dive on the whole time equivalent reductions. And we've been asked to do that by the Productivity and Performance Committee. And I think I can say that I definitely took some assurance from that that, because my question with whole-time equivalent is what are we going to do differently this year so we don't end up where we were last year. And I definitely took assurance that there are some things that are different this year in terms of being proactive and in front of this, that we didn't see last year from providers and across the system. So I think I can say that we did take assurance from that. And it's also important to recognise we've got 2 new risks that we approved, and they relate to the sufficiency of human resources, leadership and capacity for the transition, and also making sure that during the transition, because of the reduction in staff, we do not compromise 2 things: 1, our ability to deliver our operation, and 2, quality and safety. And we also noted the importance of not exacerbating inequalities through that process of transition, which sometimes happens, and we need to keep an eye on that.
Thank you, Lisa. Any comments or questions? On to Adrian then for risk and audit.
Yep, nothing to add to the written report, Kay, although happy to elaborate on any of the points if there are questions.
Excellent. And we have now caught up the time. Well done. Thank you very much. You did very well on the breaks and even quicker on that one. So we're moving now to item 7, for which I have to declare an interest. Oh, no, sorry, Paul. Yes.
So thank you. I just wanted to quick any other business and just to comment in here because it will come to whatever committee we'll be looking at general practice in. But just to highlight and for the public meeting, the GP survey, patient survey is out, and I want to give 2 headlines. Firstly, in almost all indices, we are better than the national average in Dorset, and in almost all indices we have improved compared to the previous year. So I think that good news is worth us just recognising, and Forbes, if you can take our thanks and appreciation, because although we're talking like we're taking the credit, it is general practice in Dorset, frontline general practice, who are delivering that. We will take a more detailed consideration of this and bring it to committee, and that will determine the committee obviously later on in the next cycle to look at it a bit more deep dive, because there is still a huge amount of variation within that headline figure, and we need to work out what we do around that variation. But at this point, I think it's a recognition of the good news and the good practice that's happening within Dorset. So Forbes, thank you to you and your GP colleagues.
Yes, thank you from all of us, Forbes. I normally don't let people add extras onto the agenda, but that was such good news that we've allowed it today, but we'll discuss it at a committee in future. So moving to item 7 then, and I have to hand over the chairmanship to Rob.
Thank you very much. Sorry, my camera was off. Thank you very much, Kay. We may be able to get ahead of time with this item, let alone catch up. It's something we've discussed a couple of times. If I could ask you to focus on page 85, I think the slide is very helpful about the new proposed committee structures, and I'll say a few words and then David or Liz or indeed any of the working group members may want to add. You'll remember from before, there are 3 things we're doing here really. Number 1, the executive legitimately raised that we have to make sure that we get our bandwidth right, because we are dealing with transition, and therefore the full committee structure that has been in place doesn't easily help us to have the bandwidth to then be dealing with restructure and transition issues. Secondly, as the new chair, I wanted to bring a couple of priorities to this. And thirdly, ideally, and I've discussed this with the other chairs, if we can be focused on 3 things and have 3 partnership committees that focus on these things, and we can think about that across the cluster, it helps us to align our governance in due course. We are proposing a finance and planning committee, and the shorthand for this is what I said in my introduction, that we have to deliver this year's operating plan and budget and we would like a decluttered finance committee with fewer things in it that meets monthly, and that gives Dan as the chair and Alison as our CFO and everybody the real opportunity to make sure that we have appropriate scrutiny and governance of SIPs and our financial plans, and any amelioration or that we have mitigation that we have to take. We would like a commissioning and quality committee, and of course there are some issues where the ICB will retain some statutory functions that will ultimately go elsewhere, but that will involve legislation, and so we have to make sure that we meet our statutory obligations. And thirdly, in an appropriate way, we want to make sure that we keep on top of our transformation programs, because they help to adjust the baseline for future years. And so we are recommending a finance and planning committee, a commissioning and quality committee, and an outcomes committee. And I'm grateful, several people in the room, Sam and Forbes and Adrian, as well as some people not in the room, such as David Clayton-Smith, who gave us a provider perspective on this. I'm grateful for the working group, and what you see today is what we're recommending for the rest of the year, and however long we remain as operating in the way that we are. We do have a change to propose today, so whilst I'll ask us to minute that that we approve this new committee structure. Later on in part 2, we'll have a broader discussion, perhaps less focused on the internal mechanics of the ICB. We do have a proposed change, and on the right-hand side of this diagram, you'll see that we have a remuneration committee. Remuneration committee is populated by NEDs. It's not a bigger partnership committee with external partners on it, and this is where we deal with the very senior pay issues of our chief executive and executive. We did think that with standing down the workforce committee, the people committee, which makes sense because the workforce and organisational development role will not be one for the ICB anymore. That will shift to model region in the plans as they stand, and of course providers too will take up issues of workforce planning, and it won't be an area for the ICB, and so anything we would be doing now would be influencing future years when actually it won't be an ICB role anymore. However, on reflection, the thought that we would move our internal people issues, so the duty of care that we have to staff, reorganisation, policies, staff reductions, and the very difficult job of managing that during transition, we probably wouldn't put that into remuneration committee as we thought about at the time, because remuneration committees tend to deal with very senior pay, and rather than expand its remit, what I'll propose today, and this has been discussed with the executive and discussed with the non-execs as well, is that on that right-hand side, we will have something like remuneration committee. We will keep a people committee to deal with internal personnel issues, other than those dealt with at remuneration committee. And we've met with Liz and asked her to draw up a draft terms of reference. And so if you're agreeable on that today, please, when Liz now produces terms of reference and proposed membership and chairs for the committees, it will include that I don't know how to word it really, either we retain the people committee but in a reduced form, or the people committee is replaced by a new, more streamlined, inward-looking people committee that's time limited and deals with reorganisation issues that we think are best not taken to RemCom. I suppose the bit of me in this is I'm keen on having a a finance committee that is meeting very regularly, and we've got to keep on top of our operating plan. The other thing is I'm keen for ICB committees as the new chair to be a bit more inclusive, and therefore we are inviting, the trusts, for example, to put non-executive directors on our three main committees and on the audit committee, because we think it's good that we create a sense of system through our committees where, in a positive way, our committees have been populated by our own meds and executives from the system. But I'm quite keen that boards, of course, I chaired UHD until recently, and so, I certainly thought that I want boards to feel that they're part of the system and they don't just get feedback from their own execs. And so we will be inviting representation from the trusts onto those three main boards, as well as the audit committee. And again, it's probably a very positive thing to have the trusts on the audit committee, because it can operate as a group audit committee for the system, and Adrian and audit chairs in the trust can make sure that we're not losing things through the gaps in sense of risk. So I'll stop there, please, Kay. I'll invite David and Liz if they've got anything to add, which they doubtless will. I've probably forgotten a lot with my foggy COVID brain. But if we could approve this today, and then Liz will move to the next step of formalising terms of membership and terms of reference and membership. And I'd ask that this is approved today, because we've had a couple of discussions at it already. Then later on in part 2, we'll talk more broadly about wider governance and what we do next. I'll hand over to David and Liz. I've doubtless forgotten something, David.
Actually, I think Paul has a question, a clarification that he'd like to ask.
Okay.
So thank you, Rob. And I guess it's just expanding on the conversation you and I had yesterday, and it's around the internal people risk. And I guess the ask that we would have as executives isn't that necessarily that the people committee continues as is, but that we make sure that there is a committee that looks at the internal people risk, or the internal risk to our organisation, on the organisational change that is impacting our staff, both staff reduction, staff motivation, all of those other things that are going on. And that is part of this proposal, and almost certainly time limited as we go through this process. So I guess that's the ask. It may well have to meet regularly, frequently, given the pace of change, but that it has a very narrow focus and meets for only the time that is necessary for it. So it's a light ask for the teams, but a necessary bit of governance given the risk of the pace of change that we're going through and the risk to our staff.
Yeah, thank you, Paul. And we discussed that as NEDs as well, and we're really happy to put that back on here in the way that you've suggested.
David, do you want to come in now?
Yeah, well, I think there's not a lot to add. I think Rob captured it really well, Rob. So you're doing yourself a disservice with a foggy brain if you've got that from COVID. I just amplify really the kind of, if you add in the people one now that's come up, but if you stand back and say, well, what are our kind of 3 most important areas right now, and setting us up for delivery today and the future that's coming. Those are the 3 areas, plus the people risk, and so I think that what we're trying to achieve there is that balance between being organised and well governed around the things that matter most during this period of change and great fast-paced change, and allowing our teams, because although it's exec time, our teams work on papers and updates and reports and so on. To make sure that committees and work and the business is properly run. So if we minimise that, the number of committees, we also minimise that work across the entire organisation, not just within the execs and our deputies. So that just amplifies what Rob has been saying, really. Nothing additional to bring in.
We've got Dean, then Dawn, then Rhiannon, Paula and Louise.
Thank you. It was just a question about the operating plan. Obviously, the financial element is still is very important to it, But the other part of the operating plan is the services that we deliver by spending the money as well, and where we're keeping an oversight of the delivery of the services, because there's no point in hitting the money if our residents are going to receive kind of substandard services. So just wanted to check, is that still in the finance and planning committee, or is that being done some other way?
Dan, you take that one.
Thank you for taking my question and phrasing it more eloquently than I can. From my point of view, it's not in the finance committee. On slide 85, there's a slide about oversight of operational plan delivery that does quite a lot of heavy lifting. I don't think we should be ambiguous today. I think the performance or the non-financial elements, the dean bit of the PPC meeting, I think the intent is that that's covered at board level. So you get the read across from quality, the money and the outcomes. I don't think that's clear enough in these slides. And I don't know whether that's where your brain was going, Dean, but it's definitely where I was coming from in terms of where performance will sit. And I think that's at board level rather than at committee level.
Can I respond?
Yeah, okay, Dean.
Yeah, I think that's clear. I think probably my slight worry is when you're discussing the finance element of it as well, you need to understand what the impact might be on services. So it's how we get that into where decisions might be being made in the finance and planning committee on what the impact is potentially on quality, safety, workforce and operational services.
Yeah, I think the way we came at this, if it helps, Kay, is of course if there is a finance issue or a SIP issue that has got performance implications, it's good for finance and planning committee to discuss that. So it's understanding it all in the round. The scrutiny of the whole pack and what do we know about all of our performance and the oversight of that, I think we will probably do at board level. Otherwise, we can duplicate what happens at a committee and what happens at board. I'm very keen that the board is on top of our overall performance, Dean, if that makes sense. Dan should not shy away from performance issues for the issues that are being discussed at finance committee, but the overall approach of what is our performance like overall in the pack, we will study more at the board.
Thank you. Dawn?
I had one clarification question and one just around the commissioning and quality committee. It was just that looks like a really big agenda, and just whether or not we'll have sufficient focus on both elements of that, because at the moment the quality agenda is fairly significant. So that was my question. And then my second one was the clarification. So is this an interim arrangement whilst we get into the ICB cluster, and will then it change from September, whenever it's December onwards?
Rhiannon, do you want to? Sorry,
I think this cycle will run. This format will run beyond September, but clearly, Dawn, this is for as long as we're discussing things in the ICB. This is the way we'll do it while we develop cluster arrangements for governments.
Do you want to speak quickly to the?
Yeah, really quickly. I think that has been recognised, Dawn, and I think we will have to suck it and see. I mean, we can flex how we approach the committee, and it needs quite a bit of discussion, really, not just with Pam but with Dean and others in terms of the commissioning element, because I think we need to be quite focused on what's in our line of sight on that, and how we get ready for more of a stronger role or a key role in that. So yeah, I think it's kind of suck it and see and see how things evolve.
Do you want to carry on with your question?
Yeah. So I'm broadly supportive of this direction of travel, and I think it's the right position that we've got to in terms of that whole lens on our staff through this transition period, in terms of that duty of care, etc., etc. The bit that I think we just need to keep asking ourselves in terms of how it will get absorbed. We also have a statutory responsibility for engagement, and we do need to make sure we're not so inward focused that we're not getting our population and our public who will perhaps already be wondering what do these changes mean. So it may be that that's more in the kind of cluster part, but I do think we just need to make sure that we don't lose sight of that.
Agreed. Paula and then Louise.
Hopefully that's picked up.
So I'm Paula Bennett. I'm from the Dorset Voluntary and Community Sector Assembly. A couple of queries really. The first one is around the new People Committee that wasn't on the plan when we read it. Will that have a focus around EDI as well? So looking at workforce in transition, obviously there is a greater likelihood that inequalities can happen when looking at staff arrangements, deciding on who moves, who gets promoted, where redundancies are made. So I just wondered, will it have an EDI focus? That's one question. And then the second one was to do with widening participation. Where will that sit? I mean, it would feel like it sits in the outcome, but it's not specifically mentioned. And as the 10-year plan has quite a big focus on moving people from disability to employment, then there's an ever bigger need to have that widening participation agenda as part of the focus as we move forward into the clusters.
Yeah, I would think that the EDI element of the changes will remain with the people. Widening participation, I don't think we've got yet, Rob.
Well, I think it's one of the things that we'll work out now with Liz on where best it sits in the terms of reference. I think you're right that it ought to be explicit. I think increasingly, you know, engagement and comms and things will be done at cluster level almost immediately, but making sure that we have transformation programs in place to widen participation, I think, is with the Outcomes Committee, and we'll firm up on that as we do the terms of reference to make sure we don't lose anything, Paula.
Louise?
I think my question's been answered. It was really about just making sure that you'd also got how people feel in amongst the data that you're gathering in these committees. And in the past, I've input to different committees, but not sat on any of them, and just kind of wanting to kind of make a plea for, can you make it explicit in this? Because although it's just an interim period, I think if it gets lost in this now, then it might get lost in future kind of reiterations. Thanks.
Thank you, Louise. I'll pass now to Liz because there's a couple of governance issues that she wishes to pick up, and I will, as Section A, I have to declare an interest. I'll pass the chairmanship over to Rob.
Thank you. Liz.
Are you happy for me to go then, Rob?
Yeah.
So we take away from that conversation that we've broadly approved the revised the committee review, and then we'll take those away and work up those plans in line with the comments raised today and iron out those small areas that we had that.
If it's helpful to you, Liz, before your other comments, can I take that as approved, everyone? And then that makes it easier for Kay to be in the room as if there's any questions on Liz. Liz.
Okay, so I had 4 items of governance to bring to you today. They're all detailed in the paper, so I'll just give a quick outline now. The first was the approval of Kay as the senior non-exec member. This was something that was added into the our ICB constitution at the beginning of the year in line with the new constitution released by NHS England. We already had a vice chair in place, which is Kay. The senior non-exec member takes some of those responsibilities which we previously had sitting in our vice chair role description, mostly around fit and proper person test for the chair, involvement in the appraisal, and being a sounding board. It adds in also being a point of mediation if required. So that we keep those 2 roles combined, which is something we see in lots of organisations. The chair has recommended that we appoint Kay into that role. There's no additional remuneration around that. It's just an add-on to the role that she does. So we're asking for the board's approval today. The second was to approve an update to the scheme of reservation and delegation. This was around the specialised commissioning and just formalises the powers that were delegated under the delegation agreement and the collaboration agreement, which the board had previously approved. There's no change of powers or delegation by updating this, the scheme of reservation. It's just to formalise that into that document. I'd also asked the board to ratify the decision to approve the Joint Transition Committee terms of reference, which we sent round and agreed using the urgent powers that the board has because we needed to move at pace to get those approved. We're not asking the board to reapprove the terms of reference today, but to ratify that you're content that decision was taken in the right way. We've reported it to the Risk and Audit Committee as is required in the Constitution. And finally, just to note the updated function decisions map, which we've updated to include the Specialised Commissioning Committee and the Joint Transition Committee. Normally the board see that document once a year as part of the governance handbook, but I just thought we'd bring it for completeness so that the board can see how that joint working is progressing. So
thank you.
If we can, are we happy just to work through those?
I'm very happy to take. I'll ask if we can have approval of. We've approved the committee structure. I'll ask if we can approve those governance items that Liz has just set out. The appointment of the SID onwards, and I'll ask if we can approve those. But before doing so, are there any questions, please, on any of those? I might need your help, Kay, if there's a hand up in the room.
There's one from Alison.
Thank you.
Mine was more a comment, if that's okay. So I just wanted the board to be aware that at the last PPC meeting, we did go through in terms of the risks share and the risk arrangements of specialist commissioning. So working the finance alongside the joint commissioning.
Thank you, Alison. Any other questions, Kay? Okay, so can I ask for approval on those items, please? And then that being done, I'll hand back to you, Kay, to chair the meeting. Thank you.
Thank you. And we're moving on to the items for noting, assurance and discussion. And this is the Equality Delivery System deep dive. And we have a number of people joining us online, I believe. And that would be Fran Pingarelli. Yes, yes.
Yeah.
You're going to lead, Dawn, are you? Right. Okay, so welcome to all of those who've joined us for this section of the agenda. Dawn.
Thank you, Chair. I've spoken a couple of times without introducing myself today. So I'm Dawn Harvey, I'm the Chief People Officer. And alongside Matthew Bryant, Chief Executive for Dorset County and Dorset Healthcare, we lead this agenda for the system. And Matthew can't be here today, but we've got Dawn in the room, and it's great to see partners from right across the system. So a few words of introduction from me, and then I'll hand over to Fran, and then we can move into questions and comments. So this paper tells a really important story about who we are as a system and who we want to be for our communities. The more inclusive we are as an employers, the more effective we become as care providers, and the more trusted we are by our communities that we exist to serve. So when you are reading this paper and hearing the key points from this paper, this isn't just a workforce paper, it's a population health strategy action. And as the ICB transitions to a larger footprint with a refined focus on strategic commissioning, the leadership, oversight and scrutiny of the workforce elements will continue to be taken forward by our partners and providers in the system. So it's brilliant to have our partners, providers here with us today on the screen, because the recommendations here are part of how Dorset and the wider cluster will begin to bring to life the new NHS 10-year plan. So Fran's going to take us through a few very key points to note, and then we can open up to question and comments.
Thanks, Dawn. Yeah, thanks to everybody that's joined as well to support this item. So this paper, as Dawn said, it's a system-wide reflection of where we are right now, and we've analysed some key workforce data across the system, and this is the third year running that we've done this, and so we've got some longitudinal data to kind of look back on. And the main focus of the data is the workforce, race and disability equality standard data that's come from our Dorset NHS trusts, along with some of the local council insights. And the findings show really clear progress in some areas, particularly where we're increasing the representation of global majority staff across the system, stronger leadership accountability for inclusion, and also new models like the UHD's patient first approach, which is starting to embed inclusive practices in how services are improved. But the data, I think it's fair to say, also shows some persistent and systemic disparities. So global majority staff is still significantly less likely to be appointed after interview across all of the organisations, and that disparity is increasing. And they're far less likely to be represented in very senior roles. And they're also more likely to be subject to disciplinary action, discrimination and harassment from others at work and also the public. Disabled staff also reported lower confidence in equal opportunities, and access to training remains unequal across the system. Disclosure rates for staff with disabilities also remain low, suggesting that many people don't really feel safe in being open about who they are at work. So whilst we are making progress and there is lots of good action taking place, the experience of inclusion isn't yet consistent or equitable for everybody. And this matters deeply, not just for our staff, but for our population. The NHS 10-year health plan published only last week is really crystal clear that to improve health outcomes, we must actively address the causes of health equity. And that includes structural inequality in our workforce, because the link between workforce equity and population isn't just an abstract nice to have, it's direct, and there's direct correlation. And so when our staff feel seen, safe, supported, they stay longer, they contribute more, they connect better with the communities that they serve. And when inclusion is real, staff are more able to deliver culturally competent, personalised care. And that's really vital in tackling health gaps for our marginalised groups. So in essence, this paper shows that we've got the tools, we've got the inclusive leadership programmes, we have the staff networks, we have the peer support, we have the leadership starting to take accountability, we have the data, we have system-wide kind of initiatives starting for respect and safety. But in order to shift the outcomes, we really need these to be scaled, embedded and lived every day across the system. So the recommendations in the report, which are a combination of conversations that have been had with EDI leads and chief people officers across the system, are to start to really set visible representation goals across the system and recruitment goals, especially at senior levels, that are monitored and they're actually accountability mechanisms built in. So without those, nobody's really going to be motivated to change, and we're just sort of presenting them back, and those structural biases will continue in decision making. We need to expand the inclusive leadership programs that we've already started to see really great traction on across the system, where we've been designing inclusive leadership programs like the one I'm on here today in Dorchester. We're on the penultimate day of the Leading for Inclusion programme, and the conscious inclusion, inclusive leadership sessions that have been designed as a system and they've been rolled out to over 300 people, leaders across our system over the last 18 months or so. And bias and inclusion training alone won't fix the systems that are designed to reward sameness and lack checks on equality and inequity in decision making. And training is useful, but we need the processes around that to also support the people in our organisations. And so there's something about strengthening the data and using it differently, and the accountability mechanisms. And finally, the suggestion in there that actually our staff networks are supported not just as support groups, but also as strategic partners. Networks are often consulted on, but not necessarily co-decision makers. And so representation without influence means that it becomes tokenistic, and they should have a real seat at the table with real power and influence, and to increase the diverse voice and co-production. So in short, the more inclusive we are as employers, the more effective we're going to be as care providers, and the more trusted we'll be as by our communities that we exist to serve. So as Dawn said, this isn't just a workforce paper, it is a population health strategy in action, and it's part of how we can really bring the new NHS 10-year plan to life. So thank you, and welcome your reflections and any questions.
Thank you, Fran. Anyone want to ask any questions or comments? Yes, Rhiannon.
Comment and just to highlight another point that I spotted. Fran, I couldn't agree with you more in terms of this being absolutely embedded and not just kept in that sort of context of the network. I mean, in my head, as you were speaking, you know, it shouldn't be about being, you know, waiting to be invited to the table. How can we build the kind of, you know, these networks or the partners in these networks into, for example, the neighbourhood networks, because there's a real rich source of insight that can be shared here. So I think it is, I suppose I'm really speaking to the opportunities in terms of the tackling inequalities element that both you and Dawn spoke to, but of course the best practice in terms of recruitment, retention, and how staff feel today and going forward in the future. So echo. Just in terms of one additional point, I suppose, in the bullet point that highlights around the disciplinary actions and the disproportionality on particularly global majority staff. That's also true of referrals to health professional regulators. It's disproportionate numbers that are being referred. So I think it might be quite helpful to capture that as well, because that's a, you know, if those referrals are happening where they're not warranted, or there's a question mark about why some people are more impacted than others, you know, it's a very traumatic thing to be entered into, isn't it? So we need to make sure that the right decisions are being made at the beginning. Thanks.
Any comments on that, Fran, before we move on?
No, I think it's, yeah, all part of a similar issue around identifying where those disparities exist at more of a micro level, and having the conversations, not in a calling out way that makes people feel vulnerable and worried, but actually is a calling in and a curious, wanting to understand what the decision-making process was behind that, to help educate people around some of the biases that they have in their decision-making, and how to just try and spread and adopt an approach to thinking differently about some of the decisions that are made, and how implicit kind of biases might be driving certain decisions. But I think that's got to be done at quite a sort of micro level, working with line managers, with managers that are making these decisions. So I think that's partly down to getting better data on the ground, and then having kind of more granular conversations with people. And it will be across a whole range of different things, whether it's recruitment, whether it's disciplinaries, etc. So I think that's something for, you know, EDI leads, HR business partners to kind of think about, how do we start to have those conversations where we can see the disparities arising in teams on the ground, and there's patterns emerging so they can be addressed.
Thanks, Fran. We've got Adrian, Rob and Dawn, so I'm going to ask them to make their comments or questions first, if you could respond to them after that. So Adrian first.
Yeah, thanks, Kay. First of all, thank you for the paper. It's rich in data and commentary. This is my first time in this context receiving this kind of annual update. I guess my question is, I don't know quite how worried to be. You know, lots of organisations I've worked in previously have got real challenges with representation, and the fact that we don't yet have representative representation merely represents the work in progress. Whereas actually there are some comments in here, like commenting that we've got systemic bias in the recruitment process, which would be an immediate issue. Quite frankly, as a board, we could not sit here and not have an action walking out of the room if we believed there was systemic bias in the recruitment process. So yeah, so my question is, how worried should I be? Very happy with the report, happy to lean into the recommendations, but I guess I'm asking myself, should we be doing more and more urgently?
Rob?
Thanks very much indeed. A comment and then a question. This time last year, when the riots were taking place, Siobhan and I did a number of listening events with global majority staff, and it was shocking. You know, I mean, it was really shocking. People having stones thrown at them while they're walking to work and told to go back home, and indeed people feeling that they're being racially abused within the work within the workplace by colleagues, and you know, doesn't your food stink? You know, can't you do something about it? And we were really shocked by it. And Dorset is a lovely place, but there is racism below the surface, and there is racism in our workplace, and there is racism in the community. And I think the thing that we found very hard to deal with, and we spoke about it a number of times at the board, is the sense that people feel that they report things that have happened to them and nothing happens. And I suppose that's what I want to turn into my question, really, about do we have the data that we need? And this needs sensitive handling, and we mustn't jump to conclusions. But I suppose, to repeat something that was said at the UHD board, if somebody commits fraud, they will be disciplined and they will be dealt with, and we will have management data via the head of internal audit on have there been cases of fraud where appropriate remedies have not taken place. Do we have that around these areas where if staff suffer racism in the workplace, appropriate action is taken, or where has it not been taken? Actually, we didn't feel we did. And so I think the quite challenging thing to say is I think all the things in this paper are the right thing to do, but in our organisations, are we setting through HR and management an appropriate tone about consequences and that these things are unacceptable? And we really struggled. I mean, we really debated this a lot at UHD board, because we make statements that racism is unacceptable and there will be a zero tolerance where staff suffer it. But then actually, in these listening events, people said to us, well, come on, you know, nothing really happens. And I couldn't answer that because I didn't really have data on it. Sorry to labour the point, in the way that I would have data about whether fraud has been committed. And I'm not looking for, I'd just be interested for your thoughts on that, about does this paper deal enough with ensuring that we are protecting people through there being consequences if bad things happen?
Okay, Dawn, if we take your question, and then I'll ask Fran to respond, and then we've got one from Dean.
I think we would be kidding ourselves if we thought we didn't have any inbuilt bias, societally and also organisationally. I think there's lots of evidence and research out there that tells us that this exists, and it's something we need to pay attention to. I think there are some really practical things that we need to do. So I think we need to make structural changes in the way that we run our services to actually begin to address some of these areas. So as an example, you talked, Rhiannon, about the disciplinary. So one of the things that I've set up is a Chief Nursing Officer Advisory Group. So I see every single case and we monitor actually for all protected characteristics about how many people are coming through and how many get referred on to professional bodies. So I think it's about us making structural changes to all of our organisations. So that was my personal comment. And then the second thing I just wanted to say was I spoke to Matthew yesterday. Obviously, he's the lead for this paper. And his view was that we're in a transition at the moment and that there is significant focus on this piece of work, and he remains committed to it. And he thinks that this work is incredibly important as we move into the future. And I think somebody's already mentioned the 10-year plan and the focus that we need to have. And when you think Black women are still 2.8 times more likely to die or suffer serious harm when having a baby, Asian women 1.7 more likely to suffer those serious injuries than white women, we still have those differences that we need to continue to address within healthcare.
And it does strike me that given the fact that we are going into this transitional situation, which is going to involve quite a lot of changes in the workforce, it's absolutely crucial at this stage that we have these first front and foremost to our minds. Fran, do you want to respond?
Yeah, sure. Thank you. Two really valuable points, I think. And to Adrian's point about, you know, how worried should we be? I think, you know, we've got to be alert to the risk of systemic bias. And I think as Dawn just said there, you know, you're never going to completely, we are inherently, as humans, we have our biases. It's about being aware of them and how we address them in the moment and how we make decisions, being aware of those biases and how the systems and processes can help guide us. And I think I'm quite confident that, and I'd be great for my OD colleagues and EDI leads to come in on this, but I think the paper also reflects the amount of work that's being focused in on creating the right, not just the right processes to support better decision making, but also the shift in mental models and thinking. And, you know, as I say, training will go so far, but I think it's about how do we get our leaders to build habits in where they stop and pause and think about their biases and how they might need to do things differently. And I think I'm quite confident that as long as the actions that are in the paper, they're supported to be rolled out in a consistent, thorough, scaled way, that they will go a long way. But I also think, and what's also in the paper is, and this also speaks to, I guess, Rob's point about using data more granularly. So where down on the ground are we seeing some bias in decision making? Where are we seeing some particularly, poignant cases of harassment or some? So it's not sort of at that high level, but the HR business partners or whoever it might be in the organisations are able to work with managers and teams locally and to start to shift where we're seeing some of the biggest patterns happening. And I think that would be the next level that I think needs to happen that perhaps we don't always have the time to do. And so we've got the data, but actually we're using it in a way that's not used for blame, but for education, and used in a way that can help people see things differently and therefore lead differently and lead more inclusively. And I think that
really helpful answer. Really helpful answer. Thank you.
Dean and then Sapna. Microphone.
Which is not kind of fully formed, so apologies if this kind of doesn't come across as very coherent, but it started when we were thinking about kind of how we are kind of being treated by people like me, and when you get down to groups of low representation, you're getting down to very small percentages, and percentages can really hide things and they can kind of swing quite rapidly. Is how we kind of use this or understand it from that perspective for people that are really underrepresented or low represented numbers within our population. And it really broke home to me as kind of the exec sponsor for the lesbian and gay network that we've got. We've really struggled in getting people to come along to our network to understand what the issues are. And if you haven't got kind of people there in the room with their lived experience, it's really difficult. Even when you open it up to allies as well, it's really difficult to then kind of understand those perspectives and change our services on behalf of that. So it was just thinking, so kind of it's not very well expressed maybe, but hopefully you get a sense of where I'm coming from.
Sapna, if we take you and, sorry, there's someone else with their hand up there, Deepa. If we take you two first and then Frank can respond to those.
Thank you. Thank you. I'm Sapna. I'm EDI lead for NHS Dorset. I just wanted to come in to add to Adrian's point where he asked how worried we should be. I think we have, as EDI leads system-wide, we've done some work together. We work as a community of practice, and we identified that there is a discrepancy in the ratio of people from ethnic minority being hired to the role. So we together worked and created inclusive recruitment training as well as training guide for the managers. But the pushback we had from the training managers was that they don't have time, neither for this training, nor to implement any changes. So if we can get this permission from the board, permission to these managers to invest some time in this training and make those changes, that would be really useful. The other point was by Rob, do we have enough data? So in the beginning of this year, I had an opportunity to work on case stories, one of the project which we have attached to this as an appendix. So these are most recent stories, experiences of our colleagues working with us. They could be still sitting around the table next to us. And what we hear from them, the actions they have taken after those experiences, they've actually moved on. They've left that role. Even if they have stayed in Dorset, they have left that team. So really, people from global majority very rarely come forward and speak up because of the fear of the repercussions. So I think whatever data we have is still not the real data. That doesn't tell the story of the experiences of our colleagues.
I thought the inserts we had there of actual members of the workforce talking about it were really powerful, actually, and that I think has really pushed things home. Deepa?
Good afternoon, everyone. This is my first time attending this meeting, and I'm here to represent University Hospitals Dorset. I work as an EDI lead for the trust. So yes, we have improved our REST and NVDA's data, and we were invited for a national webinar. But as an EDI lead, I don't feel comfortable, just like the fact that Sapna mentioned, there are so many cases are not reported. Another thing I would say, in UHD, there is an increased awareness about cultural integration, the issues race and racism. We talk about it like daily without any problem for the last couple of years. I can confidently say that. And I thank our CEO, Siobhan, for leading with courage and, that strength. She gives us hope. However, the real challenge is in the inclusive recruitment project, because people are not, we'll try our best. It shouldn't be when we can, it should be, we need to start acting now. And I'm quite happy to involve in any discussions if that helps, because as a first-hand, in the front line, experiencing this and listening to people, I'm quite happy to, if that's helpful. I just wanted to put it out there. Thank you very much.
Thank you, Deepa. Fran, do you want to respond to those? And then I know Dawn wants to sum up. So if you can give us your thoughts, Fran.
Just briefly, yeah, thank you, Sapna and Deepa, for your inputs there. Really powerful, and it just brings it to life, I think. And I just wanted to come back on Dean's point, and I agree. I think there's an opportunity. Sometimes, though, I think it's about the depth of insight that you get, even from a small group of people. It doesn't necessarily have to be a large group of people in our networks to give it the depth of insight and the stories that are representative of across people's experiences in our organisations. But I do think there's an opportunity that we've talked about before, and I think the time now is right for bringing the networks together and having some opportunities to bring them together and to invite them, not necessarily to mandate it, but to invite them to be to have a different role. I think that it's a missed opportunity for our networks, and we've talked about the lack of senior representation in certain protected characteristics. I think there's a dual opportunity to provide some more senior level decision making and strategic input from our networks, which not only brings strength of voice and an impact to the decision makings, but also allows them the opportunity for growth and development as well. So I think that was represented in the paper, and I think that would be something that would be worth pursuing. But yeah, I think that's all from me for now. Thank you.
Yeah, thanks, Kay. So just a final couple of thoughts to sum up, which is essentially, yes, there's been some progress. It's not quick enough, it's not fast enough, and there is lots more to be done. And we're doing it in a societal context where society is pushing back on this agenda. So finding different ways for messages to land, to be heard, is challenging at the moment. I just want to thank the work of all of our EDI leads who've joined us on the screen, who do valuable, fantastic work every day in this space and listen to some pretty horrendous stories and support people through this. So thank you for being here, and I hope that you can see how the board takes this seriously. Final point, Kay, I want to thank Fran Pingarelli for her leadership in this area. We've been fortunate to have Fran working with us since the start of the ICB. Fran's moving on to bigger and better things as we make changes across our ICB, and I just want to the board to note the leadership that Fran has shown in this space across the system, and to thank her for that.
Thank you. We've seen several of these reports over the years, and clearly I think, I'm speaking for myself now, but I'm hoping the board will share my view. We want to see the recommendations that you've got here implemented, I would think, but we really want to see some firm action on this one. We want to see real significant changes, because I know there has been improvements and lots of things here where things have improved, but it's still, especially when you listen to those very powerful insights from those on the receiving end of this, it is still something which we should not tolerate. And I'm looking around the board at the minute, seeing if we're all in agreement with that. So I think from the point of view of the board, we would strongly support you to do what you've suggested here, and perhaps to go even further and more stronger in trying to eradicate this, because it's not acceptable. And we don't see it as acceptable. Is everyone happy with that sum up? Yep. Thank you, Fran.
Thank you. Thanks, everyone. Bye.
Sorry, we're moving on now to the operational plan, and it's got your name here, Alison, but I'm assuming, Dean, you're going to be chipping in as well and adding this from your point of view, what's particularly relevant. So, Alison.
Thank you. So I just wanted to update the board. So since we came in, I think it was the end of April with the last plan, we've now issued all budget books out within the ICB, which have been signed off by budget managers. We've got those regular meetings in place, and thanks to Dean's team, we've now issued contracts to all our providers, and are in the process of agreeing a small number of contracts with providers where that hasn't quite been done. So really getting into that grip and control part. Earlier in the meeting, we had a quick update on the Productivity and Performance Committee from last week's meeting. The main focus of this was to undertake a deep dive on the month 2 financial position, which is the position I'm presenting here today. We did look in terms of the backward look and the forward look in terms of where are we at the moment, but recognising a lot of our savings plan will come in more as we go through the rest of this year. We talked about the newly developed flash report, so I'm glad that went down well in the meeting, which does the spend against each of our budgets, the riskless delivery, and the planned mitigations where we're taking where risks are being flagged at this point in the year. And we will continue to do that as we go through the rest of this year. I just wanted to highlight that in month 2, the delivery against our operating plan is in line with the plan, and the report outlines the actions that are being taken. The report also shows that at the end of month 2, the ICS was about 100,000 away from the plan we've submitted. We've developed a one-page summary, which is also appended in the packs, and the purpose of this is that summary goes to each of the finance committees within the system, and I'm now attending the trust ones as well as the ICB one. To support that, we have a weekly cost improvement tracker that we all fill in. It goes to the finance directors on a Friday, looking at our direction of travel. Are we identifying more cost improvements? Is it going in the right direction? And we also have weekly medium-term financial plan meetings where each of our 5 work streams are reviewed to understand where delivery is against the operational plan. And the focus on this is to ensure we deliver our financial plan across the year and feeds into the information we're looking at today and looking at the PPC. We've already popped a system workshop in the diary for the 22nd of July to work through what other actions we'll need to take individually and collectively in order to deliver our financial position this year. So I will just pause there in terms of, hopefully that was a brief summary of the paper, but I don't know if there's anything you were going to add to this one, Dean, or pick it up in terms of the next paper.
Can we take the financial questions first, Dean, and then I'll come to you for the operation and any other questions. Any questions for Alison on the finances part of the operational plan? Yes, Graham.
Well, I've got a point to make, which is more operational, but is impacted by the financial, which is the issue about the changes that have been made around some of the services without consultation with local authorities. And that's having an impact on our services as well. So we need to pick that up. Don't necessarily need to do it in detail in this meeting, have to do it in part 2. But I want to flag that there is contention between the two parts of the system where we believe the ICB has made some changes which it should have worked with us on before making the changes.
Is this sure?
Well, it's driven by the finances. It's absolutely driven by the finances, and it's a way of making savings within the NHS. But it's having an impact. So I wanted to flag it here because I think it has a financial impact and it's driven by that, but it is a point of contention.
Okay, so we'll pick that up again in part 2. Dean, do you want to talk to the other part of the operational plan?
Sorry, how well we are doing against delivering of the plan, particularly in areas like the urgent and emergency care, where we've had difficulty with delivering kind of ambulance handover times. They are improving significantly in Dorset, even from a good baseline where they were previously. We're delivering on the elective ones where we've got new targets this year, or restated ones around referral to treatment target. And in mental health, we continue to deliver well. So I won't go into probably any more details in the performance report, just to say that kind of at the end of Q1, we are doing extremely well. And there's a new performance framework in place with the region where we have weekly meetings to go over areas that we are under, which is participated by all the providers and the ICB.
Yes, Lisa.
Thanks, Kay. I guess I'm just following Graham's comments as well, just to say that we hear a lot about the financial drivers for the changes that are happening, but I think there is a real danger of unintended consequences, and that we actually displace when we start making changes, and it will be unintended. But if one of the things that struck me when we did the whole-time equivalent, the workforce deep dive at the People Committee, was the delicate balance and interdependencies. And if you pull a thread in one place, something happens somewhere else. And I know that Rhiannon and I have been talking about this a lot in terms of workforce and quality and safety. But it's not just a workforce and quality safety thing, is it? It's making sure that we don't hit those financial drivers at all costs, because we are in danger of hitting our targets but missing the point. And the point is the healthcare of the people of Dorset. And I don't hear as much about that sometimes as I do about the financial drivers. And I'm not saying the financial drivers aren't important. Of course they are, because without financial sustainability, nobody gets healthcare, right? But let's not hit the financial targets and miss the point of healthcare. And I guess I want to wrap in, Graham, to your point. There's a danger as well of displacing some of the problems and solutions onto the voluntary sector as well. And I worry with things, we've heard announcements about what's going to happen to Health Watch, and we know that it's hard out there in the voluntary sector, and there's a danger that that voice will no longer be amplified. So can we just be careful of the law of unintended consequences, the danger of hitting the financial targets but missing the healthcare issue? It's just I guess it's something that's been on my mind for a while, and before I go, I just wanted to say it.
Rachel?
Yeah, good morning. Apologies, I'm not with you. I've just actually sent out for a COVID test, Rob. So
it's all right.
Yeah, I hope so too. I think there's lots of positives in there, but I would draw your attention to the need to have a stronger profile on mental health. The report doesn't cover a number of data points that are in the operational planning metrics. The data for CYP access is actually incorrect, as I understand it from the team. It's not in line with published data. And there is a discussion with Sue Dehenny about why the system has not expanded its MHST in year, as that's mandated in the operational plan. So I think whilst I accept that things are improving, I do think that we should pay attention to mental health a bit more. Thanks.
Dean, do you want to respond?
happy to pick up the issues with the team, Rachel, on where they think it's not correct. I suspect with some of the mental health data, it's the delays that we get from the COOth data and other data that is there, but happy to pick it up with the team.
Thanks.
Any other questions or comments on the operating plan? Right, well, this was just for noting. We have no items for consent. We had no questions from the public. Is there any other business? Nothing was notified to me before the meeting. Thank you. No any other business. Key messages and review of the Part 1 meeting. From my point of view, I think we've got a real challenge here going forward in the next few months, keeping the focus on our own plan and what we're trying to do to improve things for the population of Dorset, while at the same time working on an organisational restructure and the beginnings of a really exciting 10-year plan which will reshape the future. I think that's going to be a really challenging balancing act for everybody on the executive and for us as the board to make sure that we are not dropping the ball on any key assurances, because we're focusing on what's going to be coming in the future. And that seems to me to be one of the things that has come out again and again during the meeting, is this, not a tension, but this need to make sure that we balance those two. Rob, did you want to comment on anything?
I think that was very well summed up, Kay, and thank you for that. And it's, as I said at the beginning, really, we need clarity with each other, don't we, on that which we are doing in the short term, that which is a transition as a medium term, because this is the vision of where we want to get to in the long term. Doing that during a period of reorganisation is very difficult. I'm sure we will make a good job of it, and the more we talk about it, the better. But I thought it was very well summed up. Thank you, Kay.
Well, just to pick up that point, really, and to expand a bit, because we have an outstanding SEND inspection that's due. It's a system-wide inspection. We did write and say we would like a deferral because of the timing. And I just thought I'd just flag with you what we got back, which was that the permanent secretary has, from DHSE, has written saying the department doesn't support deferrals based on ICB restructuring because of their firm understanding that for ICBs, nothing has changed statutorily, and that therefore their responsibilities remain. So worth just emphasising that from central government's point of view, there's nothing happening here. You know, don't know what all this distraction is, get on with business as usual. So it's just worth emphasising that that's the view of presumably DHSE and DFE as relates to SEND. I assume that relates to everything else as well, but I just wanted to flag that.
They're not wrong statutorily. We continue to have those responsibilities, but then there's all the other things. Yep. Anyone else have anything they want to comment? In that case, the date and time of the next meeting, the next formal meeting of the board, will be Thursday, the 11th of September 2025 at 10:15 in Committee Room 1, County Hall in Dorchester. And at this point, I will resolve that the representatives of the press and other members of the public are excluded for the remainder of the meeting, having regard to the confidential nature of the business to be transacted publicly, which would be prejudicial to the public interest. Thank you very much.